Well, I think I'm going to start the session since all the speakers are there, and it will be my pleasure on behalf of the World Federation Neuroanatomy Committee and the uh, two chair, Professor Benish and myself and a colleague to have the 10th webinar, educational webinar. It's dedicated for lifetime recognition of three pioneers, Japanese this time, world-renowned mentors who fulfilled the, I call it the Leonardo da Vinci principles, being balanced between art and science, being cultivating grace, dexterity, and manual chic, and they are all innovators and embrace challenges. Start Professor Kobayashi does not need an introduction. He has been long in the family of neurosurgeon worldwide. He was trained and attended at the Mayo Clinic. He was privileged to be with three famous people that I know them. Thoraf Sant, the famous vascular surgeon for the Mayo Clinic. And of course, he was with Professor Sujita for, I think, more than 10 years. And he was as well with Professor Roten for many years. And he has established himself as a vascular and skull-based surgeon. He has contributed tremendously to many aspects of neurosurgery, being vascular or skull-based, and even some complex pediatric cases. Now, without further ado, he is a human with hobbies, and I know that he is a good skier. And I was privileged to be with him at different committees and different meetings. And here he was recognized by the Saudi Society as Medal of Honor. And in that context, I'd like to thank in this picture Professor Franco Servate, the president of the World Federation, who has been very instrumental in supporting different committees, including the Neuroanatomy Committee. One day we will have him with us. This is the introduction to Professor Kobayashi, and the other one with us today is recognized Professor Takashi Kawazi. Takashi Kawazi, I was privileged to sit next to him for many years at the World Federation Skull-Based Society. He was the president of this and the chair of the committee. He has owned several ownerships and recognition worldwide and locally in Japan. He was from Keio University in Japan, and he took a vascular fellowship and liaison with Mayfield, Cincinnati, with John Tuve on a different aspects. He is, again, like the other two, is an artist. He draws his own sketches or arts. And I remember one time in China, he bought from the next to the Greater Wall these small glasses where the young people start painting inside it. He wanted to take them as a training for his younger fellows to be trained on microsurgery. So he is an innovator, and of course he will talk about the famous approaches for his name and the different approaches to the skull piece. The third one is Professor Taka Fukushima. Taka, I have known him for more than 25 years from the time he was in Japan, then he moved to Pittsburgh, and he is a great neurosurgeon in all aspects, an artist, and they include art and science and academia. He's a wonderful person and a great musician, not to forget the Fukushima band of the World Skull-Based Society. He has furnished us with a recorded presentation of him, and he will be recognized for his lifetime achievement. these are the recognition. Other speakers, they are from great speakers who have accepted to be with us on this webinar. I'd like to introduce Professor Luciano Mastroianni. He is, call him a brother and a close friend. I've known him for many years, a great skull-based surgeon. He has affiliated with Professor Fukushima. This time we invited some of the members that they know the rewardee of the ownership. Professor Luciano is the chief neurosurgeon and skull-based surgeon in Rome, and he has run several courses on teaching young neurosurgeon and peers skull-based surgery. Have Professor Volker Seifert from Germany, Frankfurt, a great skull-based surgeon, known him for many years, has contributed tremendously, and with a specific, I like always his presentation on the posterior fossa petroclival meningiomas and bilateral approaches. A great educator, he has contributed tremendously to the World Federation educational activities and science. And Professor William Caldwell is the chief neurosurgeon in Salt Lake City, and he is the editor of the Journal of Neurosurgery. He has contributed to our webinar without hesitancy on several occasions. We are blessed to have him as a friend and a contributor to this webinar. I finished the introduction, and I'd like to have the co-chair of this session will be Professor Benish from Czech Republic. I will ask him to give you remarks, and Professor Sanjeeva Jakarta from Oxford Group. He will be co-chairing this session. Professor Vladimir,
thank you, Imad. There was a really great introduction, and it's impossible to add anything because we really have very distinguished speakers, and I just am sure that we shall have one of the best sessions we have had over the past 9 seminars. The 10th will be probably one of the highlights of your chairmanship of the committee, which I really appreciate very much, and I'm sure that everyone will enjoy that. So enjoy.
Thank you. Now, without further ado, I'll ask Professor Shigeki Kobayashi to present his talks. Professor Kobayashi, everyone has 15 minutes. I think Dr. Kawazi requested a 40 minutes presentation. Please, Professor Kobayashi.
Thank you very much. Imad, do you hear me? Do you hear me?
Yes, we hear you, yeah.
Okay. Thank you for inviting me to this important session. I thank WFNS. I thank this organizing people very much. I'd like to start now my presentation.
Can share your screen.
Yes. Microsurgery of paraclinoid IC aneurysm with special reference to developing concept and some anatomical considerations. Now, where I have been working at Shinshu, which is the central part of Japan with a population of 2 million. And we have one university here. The first founding professor was Professor Sugita, and the second, now the fourth professor chairman now to present. We've been operating on 600 aneurysm per year. I'd like to talk about the paraclinoid aneurysm in particular today. Now, paraclinoid IC aneurysm are those located between the cavernous sinus and the posterior communicating artery. The treatment, clipping versus coiling, as you know, the coiling is now increasing as a treatment choice for this particular type of aneurysm. In our institution, initially, most of the cases were treated by clipping, then IVR coiling surgery has been increasing in the past some 10, 20 years, 30%. At a hospital where I'm working now is also about 30%. But in the recent couple of years, no, very few, rarely clipping surgery performed. First, coiling chosen our institution nowadays. However, let me tell you some the problem we have with the clipping surgery. Many people say visual complication is the most problem with the surgery with this particular aneurysm. If you see here, with coiling operation in a hospital in recent years, no visual complication has been experienced. However, we have some ways for direct surgery to survive. Now, what are they? One is some of the cases to overcome visual complication. The secondly, treat cases operable by IVR, such as giant dissecting blister-like aneurysm and so forth. And thirdly, to treat IVR failed cases or supplement IVR cases. Fourthly, to compete with IVR to obtain a better result. And of course, patient preference is one of the important considerations. The content of my talk today is one historical overview of the developing concept of the paraclinoid aneurysm of the ICA, and secondly, cases and recent advances. First, I'd like to talk about some points in historical overview of this particular in reference to this particular aneurysm, the attention to ICA aneurysm, and related to the arterial branching site, which was the start of my interest in this particular aneurysm. And that time was about 40, 50 years ago. That was the coinciding the dawn of the skull-based surgery. I think in that case, the importance of anatomical consideration has to be stressed. And thirdly, new ideas and the concept, any type of neurosurgical procedures developed when you confront the problem in our practice. Now, problem solving is my principle in my career of being neurosurgeon. Problems such as difficult cases, technical failures, complications. Then we think about the solution by innovating new approaches, technique, and instrument, and a new management. We do apply this to clinical cases under this new concept. Then we have to reviewing the result and so forth. And if we have problem, we have to do this again. Now, some of the talks about the skull-based approaches for aneurysm. In our experience, I talk about basilar bifurcation aneurysm, then mainly on paraclinoid aneurysm. Now, in reviewing the direction of the aneurysm clip, we have found that so many wide range of clip directions we see on CT scan after surgery. By Anterior approach, something like this, and by subtemporal approach, wide range of the clipping direction extended. As regard to the height of the aneurysm, neck extended from -10 to 50 millimeter in relation to the biclinodal line. Now, if you have a problem with a high positioned basilar bifurcation aneurysm, the solution process will be one of the ideas will be drilling the base of the temporal bone. This is the concept of skull-based approach. Then we extend to all approaches whereby exploiting skull-based bone and minimizing brain retraction with regard to the position of the basilar top aneurysm itself. If you see upper position of the basilar top aneurysm, we do a skull-based procedures such as orbital-zygomatic craniotomy. If the aneurysm is located lower, we utilize a posterior clinoidectomy, anterior petrosectomy, or transcavernous approach. Laterally deviated aneurysm, we use extended pterional approach and immediately extended position the basilar bifurcation aneurysm. We often use anterior clinoidectomy or optic and roofing. And these are the number of cases we have applied to this variety of the skull-based procedures. Now, let's go on to the paraclinoid aneurysm. You see, my mentor, Dr. Rotten, used to say about the origin of aneurysm, how aneurysm developed. He is stressing all the time aneurysm developed at the arterial branching site. Of course, there are some other theories, but his main theory was the aneurysm developing at the branching site. Now, we know the naming of the ICA aneurysm. Of course, besides the intercavernous aneurysm, this is a dual aneurysm. With regard to intracranial ICA aneurysm, we have aneurysm conventionally named after the arterial branching, such as carotid ophthalmic aneurysm, I see posterior communicating artery aneurysm, I see anterior caudal artery aneurysm 1, see distal bifurcation aneurysm, and so forth. Now, many years ago, problems encountered with ICA unrelated with the arterial branch. In 1983, we reported an aneurysm projecting in the direction of the approaching pterional approach from the near side of the ICA wall. And then in 1989, we reported an aneurysm projecting the opposite direction of the pterional approach from the far side of the ICA wall. As the former we call the dorsal ICA aneurysm, the latter we call the carotid cave aneurysms. Now, various terminology regarding dorsal ICA aneurysm been named by various authors. Superior wall aneurysm by Yasagir, blister-like aneurysm by Suzuki, and so forth. Anterior wall aneurysm by the late Sano, so forth. Now, this is one of the cases you see on the video. If you can see a significance of recognizing dorsal aneurysm, the third, three things. One is high intraoperative rupture rate. 2 of 5 cases we initially reported rupture intraoperatively or after surgery. But secondly, it had a technical difficulty, easy to rupture intraoperatively, premature rupture. And of course, as you all know, it had a different pathophysiology, such as Berry aneurysm or dissecting type aneurysm and so forth. In this particular case, after temporary trapping, we are using BEMC to cover up the rupture site around the parent artery. By the way, occurrence with this particular aneurysm in our series is 1.2%. Then remove the temporary clips. And the variety of angiography appearance you might see with regard to this dorsal type aneurysm. You see in case 1, you see anteriorly pointing with this particular angiogram. And the case 2, you see an AP view aneurysm pointing upward, and the lateral view see anteriorly projecting. And the third case, as you see, AP view, it's overlapping. The lateral projection, you see the aneurysm projected superiorly. So how do you call this? And if you further examine angiographic view, you see on a P view, usually this aneurysm pointing superior laterally and lateral view anterior superiorly. If you look at the anatomical orientation, at the coronal section, you see the aneurysm pointing superior laterally, and on the axial section, the aneurysm pointing anterior lateral. How do we call this? According to anatomy, you see Nominal Anatomical 1935 and 55, they proposed this group of naming about the location of in the intracranial location of the thing. And now, but nowadays, these group of names are used by the preference of the author. You see, we use both this group and this group interchangeably. And then is dorsal ventral applied only to spinal cord and brainstem. If you look at the ceramic nuclei in cerebrum, you see nucleus ventralis, nucleus ventrolateralis, nucleus ventralis anterior. You see, we're using ventralis, but is it limited to the structure itself? How about the this terminology? Can this be applied to cerebral vessels? I look papers in the past 1948 anatomist project proposed this name, dorsal ophthalmic aneurysm, ventral ophthalmic aneurysm, already used by anatomists. As I said before, variation, according to the variation of the ICA on the angiogram, it can be pointing anteriorly, it can be pointing superiorly. How can you call this? May better be called superior wall aneurysm. Why dorsal? We named this one the surgical view. You see, the aneurysm seems to be settling on the dorsum of the ICA, the operation. So what do we call this? Just as a nickname. Well, surgical outcome, just in brief, is this is Japan, old Japan outcome of the this is the recent other hospital cases. They're about the same. Now, how do we currently treating those dorsal aneurysm in an institution? If we have a blister or dissect type of dorsal aneurysm, we either trapping with the bypass surgery or wrapping surgery. If the aneurysm is a circular type, we try to do our best to do clipping operation. Now, let's go on to the second aneurysm unrelated to the branching site. This is the case we confronted in 1981. In this particular aneurysm, we used a Suita clip, angle defenestrated clip. Unfortunately, ended up with the occlusion of the parent artery. We went to the laboratory to solve the problem by cadaver dissection and design a safe surgical entry to this particular type of aneurysm. This is drawn by Dr. Suita, by the way. And we designed a modified ring clip for this particular type of aneurysm. Now, how does it look at the cadaver dissection? If you look at superior view, the carotid cave is inferior medially located, as you see here, and the lateral cartoon here is anteriorly located, and aneurysm sucked in here. Now, is a carotid cave aneurysm found in all cases as cadaver dissection. This is the Hitotsumatsu's work at the Roton laboratory. He found 32% he couldn't find any cave, and the other were present but in different shapes. Now, anatomy of the left carotid ring region, as we increased our surgical cases, we have noticed that the aneurysm are located all around the dural penetration site, as you see here in a statistic. Immediately laterally 62%, superiorly 36%, and laterally very few, but the 22% all around the dural ring region. So we have to be prepared for that. So we call that the aneurysm according to proximal, middle, distal from the heart, and dorsal, ventral, lateral, medial according to PNA, nomina anatomica. But then problem was we encountered by naming proximal ventral type of Y3 aneurysm, because according to specialized laboratory study, you see the internal carotid artery in this location is very complex, tortuous, difficult to say dorsal, ventral, the lateral, medial. In the paper, looking back, our first paper published in 1986, we defined the dorsal aneurysm as aneurysm of the internal carotid artery between the posterior communicating artery branching side to the internal carotid distal bifurcation. Now, how do they been called historically? You see, Dr. Yasugi initially called the ventral type of YCA, then he changed to calling inferior wall aneurysm. Other people are calling these aneurysms differently. We call this carotid cave aneurysm, for instance. And how we operate this aneurysm, the typical carotid cave aneurysm. Craniodectomy, optic sheaths are dissected, then dural ring and open, dissecting the superior hypophyseal artery region. And the carotid cave region is further dissected to expose aneurysm, not completely. And when you apply this, you have to follow the course of this tortuous artery and the dural penetration site. You have to manipulate and negotiate. Then you finish up, finishing by complete occlusion of the aneurysm. How we have been changed of coding, names coding this type of aneurysm in this location. We have started out with carotid cave aneurysm name, then we have, we use a juxtadural ring aneurysm, then currently, if only most of the time called paraclinoid aneurysm. Discussion. You see, we said difficulty orienting due to complex tortuosity of the IC in this region, dorsal, ventral, medial, difficult to call. Then nomenclature will be easier coding by branching arteries, Dr. Roto used to say to me, or by the structure surrounding this region. Then, regardless of whether SHAs causes an aneurysm or not, SHA, we have noticed that SHA is very important in terms of the visual complication. We nowadays routinely using visual evoked potential. Well, how people have been coding this type of aneurysm in this location? According to PubMed, we check the titles, how they use this type of aneurysm. The most often time, the paraclinoid aneurysm and SH aneurysm have been used. And according to PubMed, increasingly in recent years. Carotid cave aneurysm naming was once called many times, once some pause, and then recently again, we are calling, come back again. Regarding juxtadural ring aneurysm nomenclature, it has disappeared. Very few people use it. So, gripping surgeons are using this type of juxtadural SHA or something like this, and coding surgeons preferably using paraclinoid aneurysm. They don't care about the SHA or just dural ring and any structure around it. So, most often time, paraclinoid aneurysm at this time is very often called, then followed by SHA aneurysm, and then carotid cave aneurysm, both type of neurosurgeons. And this paraclinoid aneurysm, as seen on the lateral view of the angiogram, we can further subdivide into three groups. One, supraclinoidal type, clinoidal type, infraclinoidal type. Now, looking back to the dorsal aneurysm, which is not the paraclinoid aneurysm initially, but how did they call? Just tell you how do they call the blister-like aneurysm, oftentimes called, and anterior wall aneurysm, very often called also. However, it's surprising for me to see dorsal aneurysm of ICA is used so many times as well. Anyway, what I want to say is the concept of a special type of aneurysm occurred, being called by different names, by different authors. But once it is concept is known to people, the cases will increase. It's a very, very interesting phenomenon I have seen. Well, the last part of my talk will be focused on the cases and the recent advances. Three topics I'd have to mention. One is the paraclinoid dorsal aneurysm by Horiuchi recently reported. It's just to say my initial paper. Now, ruptured anterior paraclinoid aneurysm, he reported, and with that proximal dorsal aneurysm, we have blister-like aneurysm and also some circular aneurysm included in his series. And this is one of the series because of the increasing size of an unruptured aneurysm. This was operated on by Triona approach, anterior clinidectomy or dural ring dissection, then clip is placed for the anterior dorsal aneurysm or anterior paraclinoid aneurysm, according to Kinouchi. Well, second topic is contralateral approach to paraclinoid aneurysm. And this is approach is very good in order to reduce the visual deficit complication. You see here, this is mostly applied for a ruptured aneurysm. And this reported by Kakizawa from my group, you see, indication would be we have to have a wide prechiasmatic space. Then you have to have the neck of the aneurysm is close to the midline. This is the approach, contralateral approach during the anterior clinoid process, anterior tracheum cell. Dissecting dura, covering dura, and exposing the aneurysm between the optic nerves. And in this particular case, we are applying non-ring clip. Carotid cave region. We secure its lateral carotid artery in the neck prior to craniotomy. Well, as I said, the visual complication is much less with contralateral approach in a series. The thirdly, significance of the superior hypophyseal artery in paraclinoid aneurysm and its surgery. Now you can see this inferior-medially SHA, and you can see if you approach contralaterally and the prechiasmatic system, you see here SAA, aneurysm, and carotid artery. Now, Gibo from our university went to Dr. Roten to study on this superior hypophyseal artery in detail, numbering 1 to 7, average 3.4 distributing the recent regional optic apparatus and flow of the third ventricle. According to Critchett, he proposed the candelabra type of SAH. You see, in my experience, it can supply both sides. Now, this is a statistic we see in 14% SHA is originating from the body of aneurysm, while 86% at the neck of the aneurysm. Now, SHA, the most often we found the infraclinoidal type of the aneurysm here. And in that case, carotid cave aneurysm may be included in SH aneurysm group, located most popular approximately. Importance of VEP, visual evoked potential, which routinely use VEP. This is 62-year-old women. Right, I see a paraclinoid aneurysm set up an operation. The visual evoked potential is here. And then contralateral approach. This is the right paraclinoid approach, approach from the left side. The temporary clipping of the SHA, you see here flattening of the VEP, and you release it, and you come back to the former normal. And then we dissect the SHA from the aneurysm body, trying to preserve it. And again, test the occlusion of SHI. Again, the VEP flattened and then removed. So we thought it's very important to spare the SHA. Advancing the dissection of the aneurysm from the carotid cave. And applying a clip, excluding the SHI that we have tested. Postoperatively, no visual dysfunction, complete occlusion of the aneurysm. So, in summary, the developmental skull-based approach to aneurysm introduced and development of the concept of microsurgery of paraclinoid IC aneurysm reviewed, with special reference to anatomy and nomenclature, and introducing a new concept increasing relevant cases measuring, and some recent development introduced. Thank you very much for your attention.
Thank you very much, Professor Kobayashi, for this comprehensive review of the paraclinoid aneurysm. We might open for one comment, if any. If not, I'd like to...
Imad, can I make a comment?
Very, very short, because we are beyond time.
Yes,
okay?
yes. So I'm indeed very happy to see Professor Kobayashi and Professor Kawase and to hear this wonderful, great lecture. I think this lecture has come out from very extensive microvascular surgical experience, which is absolutely profound. You see the number of basilar top aneurysms, the number of paraclinoid aneurysms that Professor Kobayashi has done. Now that era of fine microsurgery is gradually but surely diminishing, but his legacy and his work will always remain, at least in the history of neurosurgical books. Congratulations, Professor Kobayashi.
Thank you.
Thank you, Atul. This is wonderful. Okay, well, thanks, Professor Kobayashi. I will move to Professor Takashi Kawase, a close friend and a pioneer neurosurgeon. And he is going to talk about the anterior petrosal approach. when I put it Kawase approach, he said, no, put it anterior petrosal approach for the petroclival vision and high vascular pathology. Professor Kawase, I just want to quote one statement from him. In one of the interview, they asked him, what is the recipe for success? He said, technical skills, science, and heart. And of course, heart, emotional, intelligent. He kept this part in his practice. And Professor Kawase, are you ready?
Yes. Okay.
Go ahead.
So this one.
Very clean.
Okay. Can you see? Okay. No. No. Okay. Can you hear my voice?
Yes, we can.
Okay. So thank you for your introduction. So today's my topic is anterior petrosal approach. And I will present anatomy, indication, technical points, and so on. ちょっとさ、これオンライン。Wait minutes.
Yes, the play button on the left, I guess.
Yeah. Okay.
Left.
No. Wait a minute, please.
Wait.
Okay. I can't present it. Or okay. How can I come back? Yeah. Right. I can't erase this one. No,これ. How to erase this screen?
What's the problem, Professor?
I have no idea. To I can see my slide now.
You are on presentation mode, maybe.
I have no pointer, so I can't point out here.
Yes. Can you press escape button?
Yeah. I have no way to come back. Yeah. I want to erase this screen, but okay. Oh, なんだこれ。
Pablo, would it help to take control of the
I have
screen?
no way to point out. Oh,
Say again, Sanjeev.
One of us can take control of the professor's screen.
Mm,
Do you think that would help?
I guess we cannot do that, Sanjeeva.
I can try.
so I'll try again later. So please skip to the next speaker. Yeah. I have no way to.
Matt, we cannot hear you.
I have no pointer, so I can't change the screen.
Okay, should we defer your presentation to follow?
Yeah, please stop my presentation and
Yeah.
skip to the next speaker, please.
Okay, Professor Ohata, would you like to present your talks, Professor Ohata?
Yes. After Ohata, I'll present.
Okay. Professor Ohata, will you be able to start your presentation? Unmute yourself, Professor Ohata.
Mm-hmm.
Unmute yourself, Professor Ohata. Ohata. Professor Ohata, do you hear me?
Yes.
Yeah, Professor Ohata, would you be able to give your presentation?
All right. So
okay,
have
we'll ask you to share your screen.
All right. So I hope you can see me and hear me.
Yes.
Okay,
I will see
so
the
thank
nice
you.
slide of you and Professor Hakuba.
Thank you very much, Professor Kanan, for kindly inviting me to the Neuroanatomy conference, committee conference. This is my great pleasure to have an opportunity to present a combined pre-sigmoid approach, which first presented by Professor Hakuba Akira. He is my mentor. So let me start my talk in probably I need 20 or 25 minutes. So this is a concept of the transpetrosal approach. This is a combined approach, really combined approach, because this is a combined with just a moment. This is just combined with a mastoidectomy, posterior petrosectomy, craniotomy, and tentoriotomy. So firstly, we use the combined for the combined transpetrosal transtentorial approach. Nowadays, we use this combined term for combined anterior and posterior transpetrosal approach. So he published his paper 1977. So I want to show you later. So this is the extent of exposure by the transpetrosal approach. It's anteriorly behind the optic chiasma and inferior posteriorly down to the jugular valve. This is the extent of the exposure by transpetrosal approach. If you like to expose inferior to the jugular valve, you must combine with suboccipital approach. And of course, if you like to expose anterior to the optic nerve and carotid artery, you must use anterolateral approach such as telunar approach. This is a first report by Professor Hakuba. This is a first report of the transpetrosal approach in our neurosurgical field. This paper published in 1977 for the present total resection of the 6 cases of the crevasse meningioma. This is a relatively large skin incision, and this is a sigmoid sinus and the superior petrosal sinus transected, and this is the tumor exposed. So this is when I joined his department as a neurosurgical resident in 1980. This is an operation record written by Professor Hakuba. This is, this is difficult to read for you. This is a transpetrosal approach with division of the left superior petrosal sinus. This is a skin incision, same as we are doing nowadays. And this is a facial nerve mobilized. Unfortunately, maybe facial nerve is injured, and cochlea is opened, and the internal carotid artery is opened. This operation performed 40 years ago. Unbelievable. And this is from the chapter of Professor Yasagel in the crime bureau textbook. Yasagel introduced transpetrosal transtentorial approach. That is why I said this is a combined approach with transpetrosal and transtentorial approach. This is a so nice sentence I want to read. Extension of the subtemporal approach have been described trans-labyrinthine transtentorial route. Morrison and King has modified to a transpetrosal transtentorial approach by Professor Akira Hakuba in 1977. This is included. This includes mastoidectomy and posterior petrosectomy and removing bone to expose the sigmoid sinus down to the jugular valve. That is why I mentioned this is a combined approach, transpetrosal combined with the transtentorial craniotomy and mastoidectomy. This is a really complicated approach. So this is after his publication in 1985, he reports some basic technique of a Hakuba approach. And this is nowadays we are using the same technique. This is consists of the partial labyrinthectomy without hearing loss and division of the superior petrosal sinus at its anterior part. This is now we are using technique. This is a hearing preservation, and this is a schematic drawing. He used this technique to the craniopharyngeal resection with hearing preservation. We performed the further technical improvement in the department. We published the technique mobilization of the geniculate ganglion in the anterior transpetrosal approach. This is already published by Professor Atul Gore, my friend. He is maybe hearing my talk. I use this approach in the transpetrosal approach. And the safe exposure of the sigmoid sinus is very important technique, because 1998 I published complication after sigmoid sinus injury in the transpetrosal approach. Some cases have the severe continual hemorrhage. And so we published a minimal transpetrosal approach. This is a relatively small craniotomy, and we target the region, and the extent of the craniotomy is relatively small. And then after that, we published the dural incision in order to preserve the venous flow. This is, I will talk later. And so, we published a transpetrosal approach to resect the cavernous sinus meningioma. This is also very, very valuable technique. And now currently we publish the mini transpetrosal approach. We pay our endeavor to reduce the radicality of invasiveness of the transpetrosal approach. So I want to show my technique. This is positioning. There is a two positioning in supine. One is supine lateral, the other is semi-prone park bench position. I prefer to use the semi-prone park bench position because Japanese people is not fatty. When I operate in abroad, I use supine lateral position. This is a skin incision. This is one of the, I already mentioned this skin incision in the operation record of the Professor Hakuba. Written is 1980. Skin incision same. Next is harvesting the pericranial flap. This is very important because the transpetrosal approach has a potential complication of the CSF leakage. We must reduce this complication using this good pericranial flap. This pericardial flap is consists of the temporal fascial flap, which connected to the sternocleidomastoid muscle with auricularis muscle. I show this is after the harvesting the pericardial flap. I show the technique. This is very, very important and very simple technique. This is a temporal fascia is taken and with connected to the sternocleidomastoid muscle with auricular muscle. This is very important technique because there is no barrier. This auricular muscle is like barrier. We must connect this temporal fascia to the sternocleidomastoid muscle. This is a very, very nice pedicle flap. After using this technique, we insert a spinal drainage just 2 days or 1 day. So this is a very, very well vascularized flap. Of course, there is no vessels, but I know this is a very, very good flap. I want to show you how to use this flap. This is after the tumor resection. This is on the right side. The mastoidectomy part of the bone resection is covered with the abdominal fat. And then I insert the pericranial flap. This is flap. You know, this flap entirely covers part of the mastoidectomy. Very long. It reaches the midline. Is good enough. And then we, after this, we perform the splitting mastoidotomy because of the cosmetic reason after the operation. Before this splitting mastoidotomy, you must carefully check the preoperative CT scan. There is so much variation of the shape of the sigmoid sinus. This is a protrusive type on this side, and if the approach side is dominant side, you must be carefully perform the sigmoid sinus exposure. So I want to show our technique of the sigmoid sinus exposure. We have some 7 terrible experience till the 1998. Out of the 143 cases, I already present this complication in the Journal of Neurosurgery. So I like to recommend you to expose the sigmoid sinus. Firstly, use a dissector. This blunt dissector inserted, of course, under the direct vision, and then punch out. Of course, the mastoid mesoid vein must be carefully exposed by the drill. This is the most dangerous part. This is very fast. I want to show my technique. This is a right-sided approach. After the temporal suboccipital craniotomy, we are doing the splitting mastoidotomy. Because of the cosmetic reason, we can cover this bone defect with this outer table of the mastoid process. And I directly insert the blunt dissector and the bone outer to this sigmoid sinus is punched out, ronged out. This is very fast, very fast. And of course, I use eggshell technique, but eggshell technique using drills is very dangerous. Sometimes drill jump and injure the sigmoid sinus. Of course, some parts, this is mastoid mesoid vein is carefully exposed by the drill. And then also I use the same technique, dissection and longe out, dissection, longe out. This is very fast and safe. And then we must expose the temporal base. There is, of course, very, very usual anatomy. Anatomy is very important. This is each neural structure has a dura propria. This is a dura propria of the gastrin ganglion. Must be separated of the dura propria of the temporal lobe. There is a loose areolar tooth. So this is very important to wide exposure of the middle skull base. And then you must have imaginary anatomy inside the temporal bone. This is a middle skull base. This is behind the petrosal bone. This is a GSPN, stem cell canal, facial ganglion, genetic ganglion here, GSPN. On the lateral side, stem cell canal must be exposed. So this is now I show some photo. This is a temporal base. Foramen spinosum exposed and the middle meningeal artery are coagulated. and then GSPN is exposed. This is a most important landmark in the transpetrosal approach. You can identify this structure using electrical simulation system, of course. And then I'm exposing the posterior surface of the petrosal bone. This is end lymphatic sac. This is important for me because I usually perform the partial labyrinthectomy approach. Now, entire surface, anterior posterior surface of the petrosal bone is exposed. This is very important. And now I start the petrosectomy approach. I usually like to perform the partial labyrinthectomy approach. Of course, we can easily perform the anterior petrosectomy resection. This is a lateral view. This is a partial labyrinthectomy performed to the superior anterior petrosal canal and posterior semicircular canal. This just this is just a few millimeter, but in the deeper area you can gain the wide field. And this now I start the petrosectomy. After the air cell resected, there is a compact bone around the lateral semicircular canal appeared. Partial labyrinthectomy around the posterior semicircular canal carried out, and the superior semicircular canal is also partially resected and go down to the internal auditory meatus. Some part of the meatus is exposed, and then I'm now drilling the trigeminal impression, and then so petrosal apex is drilled out. This is a usual common technique of the transpetrosal approach. And the next importance is dural incision. This is also important. There is a many important steps in the transpetrosal approach. This is a sigmoid sinus on the lateral view. This is a superior petrosal vein and the sinus. We are doing to keep this flow from the posterior fossa through the superior petrosal vein to the superior petrosal sinus to the transverse sigmoid junction. This is a dot line is showing the dural incision. This is very important. I usually our department, this is a standard technique because usually in case of the meningioma, this meningioma occluding the anterior part of the superior petrosal sinus. If you cut this part, patient has a congestion of the venous flow through the superior petrosal vein, and patient does maybe have a serious complication. This is my also I have this kind of complication for the last 42 years. This is a very, very philosophical illustration regarding the dural incision through the below. This is, this is a transpetrosal approach. It's basically epidural approach. So, and we can lift up the temporal lobe and the cerebellum together with dura, so, and venous structures. This is really complicated to understand. So I want to show furthermore. After the dural incision, this is a division point of the superior petrosal sinus, and we proceed towards the middle side for the tentyrotomy. This is the trochlear nerve on the right side. Trochlear nerve, of course, must be preserved, and the trigeminal nerve is now ready to open. And this is a Meckel cave. I like to open the Meckel cave because usually a region located medial to the trigeminal nerve. After opening the Meckel cave, we can mobilize the trigeminal nerve. I can show you later this technique. And this is a schematic drawing of the transpetrosal approach. Craniotomy, mastoidectomy, petrosectomy, and tendyrotomy. This is combined, really combined approach. I want to show several cases. This is first case is a little bit small case for the expert, and this is a posterior crinoid meningioma. I want to show this case to show the conservative petrosectomy approach. This is the approach from the on the right side. Middle meningeal artery is coagulated, and this is a GSPN exposed and marked with a dye. This is a sigmoid sinus, And this is a dangerous part. This is a emissary, mastoid emissary vein. This must be carefully exposed. I can use drill to expose this is dangerous vein, and then entire part of the orifice is exposed, and then coagulate. This is a very important step. If you insert the bone wax, it may occlude the sigmoid sinus and interlacerate the sigmoid sinus. This is a very important step. Otherwise, I don't like to use a drill. I insert the blunt deceptor, and for the sigmoid sinus exposure, this is for your orientation, and then use a longule out. This is very fast. Not like VP shunt, but very fast. We can complete the bone work in the 1.5 hours. And some part of the sigmoid sinus is exposed because here is a suture. Mastoid occipital suture is here. Suture is very dangerous part, so I use and then I start the mastoidectomy. This is a mastoid antrum. This is a good landmark and performs, and this is a compact bone of the lateral semicircular canal, superior semicircular canal, posterior semicircular canal, and this is an endolymphatic duct. I usually transact. Don't worry, patient never lost a hearing, and I really go to the anteriorly, and then I start to cut the dural incision from the anterior part of middle skull base, and this is sigmoid sinus. Until to the sigmoid sinus, dural incision carried out. This is a superior petrosal sinus. The incision go forward medially, and then I check the subdural space to find the superior petrosal sinus vein. This is a vein. This is the entrance of the superior petrosal vein to the sinus. This is the most important step. There's a many important steps, and I perform the anterior petrosectomy. This is petrosectomy performed to transact the superior petrosal sinus as anterior as possible. This is now suture now started, and then ligated, and the superior petrosal sinus is transected, and tentorium performed. This is very close to the cavernous sinus, so some bleeding coming out. It's I don't like to use a coagulator because it coagulates other venous structures. I use a clip and tentoriotomy carried out. This is now tentoriotomy to the tentorial hiatus. This is oculomotor nerve. This is to show the petrosectomy, not to show the tumor resection. So this is after the operation. There's no contusion. I want to show this case, but Dr. Kana asked me to talk before the Professor Kawase, so no video, please, here yet. So I want to show this next case. This is a middle cribus meningioma. This is a real petrocribal meningioma as well. And I show some cranial nerve mobilization technique. This is a macrocave. I already talked. This is a left-sided approach. Now, partial labyrinthectomy already performed. And I start to remove the trigeminal impression to expose macular cave. Now, macular cave is now being opened. Anteriorly, we can gain the 1 centimeter. 1 centimeter is good enough to mobilize the trigeminal nerve. So, and then, this is a very safe. And this is a fourth nerve. So surprisingly, sixth nerve shifted to the cranial side. So this is a characteristics of the middle cribus meningioma. If you use a suboccipital approach, it's so difficult to find this sixth nerve. And then there is a wide space. So exposure, we need 2 hours to expose this part, but tumor resection is very fast. No, there is a many wide area to insert any kind of the instrument. This is the entrance of the sixth nerve. This is the cranial side, caudal side. This is seventh nerve, sixth nerve. This is a little bit confusion regarding anatomical understand. This is a particular situation in the surgery of the petrocribus meningioma. I'm now going downward. This is a exit zone of the sixth nerve. This is the brainstem. This is the final station of the situation of the tumor resection. This is a caudal side, cranial side, fourth nerve, sixth nerve, 15, cranial side. Total resection, nearly total resection. I don't want to use the total resection. So this is outcome. I follow this patient actually 15 years, there's no recurrence. Of course, some part is still I'm observing. So this is the next case. This is a modified Hakuba approach. This is a little bit complicated case. Patient is 49 years old, female with progressive difficulty in gait and swallowing disturbance. 3 years back, patient has a left suboccipital approach, and after the operation, patient has operation in the other institution. Patient reports left lower cranial palsy and rigors of the radial tumor. So tumor is accessed already the left-sided, this cranial nerve is damaged. What is the next step? And there is a very, very type of adhesion. If you use endoscopic approach, there is a very danger to injure the brainstem and the basilar arteries. My selection is a middle fossa approach, mobilizing the geniculate ganglion. This is a geniculate ganglion mobilization technique. Also, this is reported by my friend Professor Turgoel. I want to show my technique. This is a little bit complicated approach. This is a position in the supine lateral on the right side, and this is a semester canal. This is a partial labyrinthectomy approach, and I'm exposing the geniculate ganglion. In some cases, geniculate ganglion and the facial nerve J-spine is located under the bone. We must find the tumor. I'm sorry, something wrong. So anyway, so this is geniculate ganglion here. So posterolateral mobilization of the geniculate ganglion performed. And then I'm sorry, some of this is, what is this? Okay, so I can't show my beautiful, anyway, so. This is after operation. I'm sorry, I can't show the video because this is something between me, myself and the screen. So this is a post-operation. I mobilize trigeminal nerve, sixth nerve, 2 nerves in this approach. So I operate this case 8 years ago, and I got my patients and still happy. And then I want to show you the very large petroclival meningioma. This is a total petrosectomy approach. This is a very complicated one. We need a space. I perform the facial exposure from the petrosal segment to the cisternal segment. I mobilize the facial nerve downward, and there is a wide space. This is a high level of the bone drilling technique is required. Third nerve here, fifth nerve here. Usually there is a tight application of the tumor to the fifth nerve and many cranial nerves. This is a fifth nerve. Dissection is impossible. There is tight adhesion. This is a real petroclival meningioma. If you use a suboccipital approach, you cannot remove like this. This is basilar artery, and there is a caudal part of the tumor. I'm using a cursor to avoid any injury of the abducens nerve. If we continue to dissect the basilar artery exposure, we may cut the abducens nerve. This is abducens nerve of the contralateral side. So now this is I have a wide space because I mobilize a facial nerve. This is also ICA is completely involved inside the tumor. We must of course preserve this important artery. And this is a final situation. You know, exposure is important. Exposure is everything for tumor surgeon, as Professor Yasugiru said. This is a sixth nerve in the root exit zone. Exposure is everything. Minimally invasive technique is meaningless in this kind of the monster tumor. This is after operation. Now 6 years passed. Actually, 10 years passed. I, of course, send the patient to the Gamma Knife Center and well control. So this is a patient come to my clinic in the wheelchair. Now patient completely independent. Finally, this is a final case, last case. This is currently performed. We performed the tumor resection, fused petroclival meningioma. This is a neuroanatomy conference. So I want to show you the importance of the anatomy around the cavernous sinus. There is a very important ligament, anterior crinoid fold, and posterior petroclinoid fold, and intercrinoid ligament here. Third nerve is completely protected by these ligaments. So we can divide the tumor, the part outside to the oculomotor nerve, tumor medial to the oculomotor nerve. So firstly, we remove the tumor by the microscope, and next, 1 month later, we use endoscopic endoscopy approach to achieve the tumor total resection. So I have no time, maybe time is limited. I just show that this is, I already showed the technique. So this is a petrosectomy, and this is the final stage of the operation on the right side. Sixth nerve, fourth nerve, fifth nerve, fourth nerve, every cranial nerve is preserved because I leave the small part in the around the cavernous sinus. You know, this is after the operation, tumor left behind inside the cavernous sinus, behind the clivus. I don't like to leave the tumor as it was. Next is tumor resection through the nose. This is an endoscopic endoscopy approach performed by my fellow Dr. Goto. He is now professor in the department. We perform the endonasal endoscopic approach. This is a very complicated approach. We already published posterior crinoidectomy approach. Internal carotid artery is exposed, and we pushing this carotid artery to the lateral side to remove the tumor from the cavernous sinus. So, you know, skull-based surgeon must use open skull-based surgery technique as well as endoscopic endonasal approach. We must do everything. So this is, technically not so, of course, important, but no time to show everything. I want to show my philosophy as a skull-based surgeon. Remove, and followed by removal. This is final stage of the operation. And then this is a final outcome of the patient. There is no cranial deficit. Of course, patient has a trochanteric palsy, but usually otherwise okay. Of course, some tumor left behind, but this is I think nearly total resection achieved. This is a final slide. Distinct element technology for skull-based surgery has many elements. Optic technology now, surgeon skill, information intelligence, and one of the most important is the skull-based anatomy. So, conclusion, I want to say transpetrosal approach continue to be an essential procedure for the skull-based regions. Anatomical understanding is a distinct element factor for the treatment. Thank you so much for your attention. Thank you very much.
Thank you, Professor Ohata, for this very nice presentation. First, Professor Ohata has contributed tremendously to skull-based advancement. Thanks for sharing the points you have modified on the Hakuba approach original, because it makes sense. I want to refer to a nice publication of yours that I always teach my resident, the reversal of the venous drainage on the skull base during doing these cases, because sometimes it's completely reversed when you cut on the tentorium. This is a fantastic paper that you have done with the CTA, and MRA. Needless to say that this is a complex approach, but once you perform it, it opens widely the skull base for you from cranial nerve 2 down to cranial nerve 11 or 12. Important to drill further down all the way to the jugular bulb to mobilize the sigmoid sinus, and I think you show it in your intervention. Thanks again, Professor Hakuba, for accepting this invitation and speak few words on behalf of our legend and well-known and remain in our memory, Professor Akira Hakuba. Now we want to check. Thank you. I want to check if Professor Kawase is ready with his presentation. Unmute, please, Professor Kawase. Unmute yourself. I cannot hear you, Professor Kawase. You have to.
Okay, can you hear me? Okay.
Yes, now I can hear you. You can share your screen.
Okay.
All
I'll
right.
try.
Yeah, let's give it another try. A different, but the same approach. But the same approach, Kawase approach.
Okay, yeah. Oh, can you hear? Can
yes,
you?
I can hear you. You need to share your screen.
Oh. Okay, can you observe my slide? No?
Not yet. You
Not
need
yet.
to share.
All right.
You need to push the green button.
Oh. How to come back, yeah?
画面の共有ボタンを押してもらったらいいですよ。画面の共有ボタン、真ん中にある青いグリーンの。
Escape. Yeah. Oh, come back to the same one. これ先にあれかな。システムが変わったね、これ。
画面の共有ボタンって先生ありますよね、真ん中の下に。
共有ボタンを押してもいいけど、これこうなっちゃうの。ああこれ、どうなんの？
共有ボタンを押されたらいろんな画面出てくると思うんですけどね、その中の一つを。
だから、今共有を押したけど、これを見たいんだけど、これが出てこないの。
あ、なんか出てきました。あ、OK。
Okay, can I start here?
Go ahead, please.
But, 共有、再生だな、これ。再生。
もう先生見えてますから、再生のボタン、左。
Okay. Okay, I'll start my lecture. The Dr. Ohata presented a very nice lecture, but it is very professional. So I'll talk about the more simple approach, anterior petrosal approach. So this approach was developed in 1985. And initially it was applied to basilar trunk aneurysm, but gradually indicated to the petroclival tumors. This is one excellent example of a dumbbell-shaped trigeminal schwannoma extending into middle and posterior fossa. So it can be removed but only by this approach. So I will talk about this. First of all, I'll talk about the anatomy of the petrosal apex. So the petrosal apex is covered with tentorium, and the anterior part is separated by the capital sinus. And it is connected with Gruber's ligament to the creeps. So the under the Gruber's ligament, fifth nerve passing through, and between the tentorium and the Gruber's ligament, fourth nerve running. And the abducens nerve crosses just under, it running inside the inferior petrosal sinus. So this is the sagittal section. Pointer is not up here. So this is the sagittal section along the trigeminal nerve. So Meckel cave is very wide space. And it is, the trigeminal nerve is compressed by the petrous apex superiorly. So by opening the Meckel cave, by cutting the Gruber's ligament and the removal of the petrous apex, you can mobilize the trigeminal nerve very easily. So the petrous apex has no organic structure. The posterior part include so auditory organs and facial nerve. However, the anterior part has no organs. So if you drill off this petrous apex, this part is very small, only 2 centimeters in diameter. And you must check the location of geniculate ganglion. It is located very superficially under the bone, only 1 or 2 millimeters just under. So do not resect this area. Dr. Ohata is a professional one, so he demonstrated. But I don't recommend to resect this area to preserve, not to injure the seventh nerve. And abducens, you must check the location of abducens nerve. It is just on the tip of the petrous apex. So do not resect the bone widely toward the crease. You may injure the abducens nerve. So next, I'll talk about the indication. So this is a CP angular meningioma, not a petroclival meningioma, but some neurosurgeon may say this is a petroclival meningioma, but it is not. It is enough for retrosigmoid approach. So, and this is, it looks like a petroclival meningioma, but it is not. It is a lower clival meningioma. So note the height of tumor attachment. The main attachment is lower than internal auditory meatus. So if you apply this anterior petrosal approach for this tumor, you cannot observe the lower half of the tumor. So it is indicated by the retrosigmoid approach. So the indication is not the tumor size, but location of the tumor touch. Attachment superior and anterior to the internal auditory meatus. So this is one good example of this approach. So the tumor attachment is located anterior to the internal auditory mass and superior to the meatus. And the tumor extending into the metal cave. So this is a good indication. And if you apply the little sigmoid approach for this tumor, the trigeminal nerve may be hidden by the tumor, and the seventh nerve, eighth nerve complex, and the petrosal vein are on the tumor. So you must mobilize those nerves and increasing the risk of injury to those nerves. So this is a surgical view by the anterior petrosal approach. So only the trigeminal nerve is on the tumor. You are not necessary to expose the facial nerve. And trigeminal nerve can be mobilized after resection of the pyramid. So, and the superior petrosal sinus can be preserved by detachment of the petrosal sinus more anteriorly. Dr. Ohata also mentioned about this. So the facial nerve is not exposed, and access to the metal cave is very easy by this approach. By the suboccipital root, the metal cave is the deepest point. However, by this approach, metal cave is most superficial part of the tumor. So by the anterior petrosal approach, no damage to the cerebellum, no damage to the temporal lobe, because this is an epidural approach. So this is the classification of so-called petroclival meningioma. So there are three types: upper clival, sphenoclival, and petroclival. So upper clival is has an attachment medial to the trigeminal nerve, and the sphenoclival have extension, tumor extension to the middle fossa. So both types are indicated for the anterior petrosal approach. However, for petroclival type, this tumor extended more posterior to the internal auditory mass. So attachment is wider than this. So this is one example. Dr. Ohata mentioned so much. So I do not talk about this. So broad attachment extending posterior to the internal auditory mass. It is indicated the combined petrosal approach. So next, I will talk about the surgical technique. This is the positioning. Head is positioned laterally, and the supine position, supine lateral position. So my voice is recorded. Neural approach is very important to spare venous complication. This is the positioning. The head is rotated laterally with the shoulder pad. The upper body is elevated 20 degrees. The anterior incision is straight and curved along the temporal line to expose temporal muscle. This is assistant view. The temporal fascia is exposed. The fascial flap is elevated from the muscle to use for closure. The temporal muscle is elevated from the skull and retracted anteriorly. This is a surgeon's view. Exposure of zygomatic arch is very important to create a crinotomy inferiorly. The crinotomy is made along the schwannoma suture with 3 burr holes. The size only 5 centimeters in diameter. The crinotomy must be made flush to base of the middle fossa. Okay, once again, so the temporal fascia is elevated from the muscle, and the muscle is retracted more anteriorly. And very important point is to expose the root of zygoma. It is a good landmark of this approach. And the size of craniotomy is almost the same to the schwannoma suture. So it is only 5 centimeters in diameter. And the bone resection just under the zygomatic root of zygoma is very important to access to the foramen spinosum. So, so this is a movie to access to the foramen spinosum. Foramen spinosum is the deepest point of the middle fossa. So the middle major artery is coagulated now and detached. So this is the anatomy of GSPN, greater superficial petrosal nerve. It's running in the bone groove. And it is adherent to the outer layer of the dura. So initially I exposed by separate the dura, but sometimes I made the injury to the GSPN. So the dura adherent to the nerve is cut only one layer. So periosteal layer of the dura is cut along the nerve. So like this. So this is GSPN. GSPN is left preserved by leaving the periosteal dura on the nerve. So this is a technique to preserve the greater superficial petrosal nerve. So periosteal dura is left on the GSPN and the pyramidal apex exposed. This is anatomy. The GSPN is the good landmark, lateral landmark of the petrous apex. And the arcuate eminence is a posterior landmark of the petrous apex. So the petrous apex is drilled off by 2 landmarks. So this is an example of, this is the GSPN, and this is the petrous apex, and this is the arcuate eminence. So drilling start to preserve arcuate eminence and the GSPN. GSPN here. So I sometimes use bone tooser. It is a very safe tool for to resect the small part of the bone. And this is after resection, you can find the dural bulging. It is a internal auditory mass. So, if you extend the bone resection more laterally, it may cause a lot of complication. Because if you extend the bone resection laterally, you will expose the geniculate ganglion, GG. GG is a geniculate ganglion. This is like a genu of the facial nerve. It looks like a genu. So by cutting the GSPN, you can expose this geniculate ganglion, but it is located very superficially. So very fine technique is necessary. So do not try to expose this area. And the cochlea is just under. So you may lose the cochlea. You may you may cause injury to the cochlea. So do not overdrill laterally by cutting GSPN. So it causes a risk of injury to facial nerve, cochlea, and more laterally, ICA, and eustachian tube. So after this resection of the bone, the incision of the dura started from the middle fossa, number one middle fossa in T shape. And the next step is the opening of the posterior fossa dura, number 2. And after this, the sinus, petrosal sinus is ligated. And after double ligation, number 3, cut the tentorium. And please note the fourth nerve courses along the tentorial notch. So this is the example to cut. This is the middle fossa dura cut in T shape, and it is extended along the petrosal nerve, petrosal sinus. And this is the posterior fossa. This is the posterior fossa, and the sinus is ligated using this is a very convenient tool named maniceps. It is very easy to ligate the sinus with this maniceps. And this is the fourth nerve crosses along the tentorial notch. Do not take care, not the injury. And the next step is to open the metal cave. So just under, you may find the root of trigeminal nerve. And by cutting this area, this is the Gruber's ligament. Gruber's ligament must be cut by a small knife. So micro knife is very important to cut it. Only 1 centimeter anteriorly, you can observe the metal cave. You can make the trigeminal nerve free from the cave. And after this, you can mobilize the trigeminal nerve very easily. So this is the anatomy. And behind the trigeminal nerve, sometimes you can find the basilar trunk and the ICA junction. And this is the one example of upper clival meningioma, not a large one. And most of the petroclival meningioma has tumor feeders from the tentorium. So on the way to cut the tentorium, you can coagulate the tumor feeders before tumor decompression. So I don't expose the facial nerve intentionally. So after cutting the feeding artery, gradually you can remove the tumor without bleeding. This detachment of the feeder is not possible by the suboccipital route. So this is after removal of the tumor. Sometimes the petrosal vein is so on the tumor. So if you can confirm the petrosal vein, you must detach the superior petrosal sinus more anteriorly. So if the tumor extends into the Meckel cave, the removal is very easy by this approach. And this is the one example, very huge clival meningioma. The tumor length was 6 centimeters. But please note, this tumor has a narrow attachment. So it is like a giant aneurysm with narrow neck. So the attachment can be covered by this approach. And the feeding artery, you can find the feeders inside the tumor. It is located within this approach. The surgical space is only 2 centimeters in diameter by this approach, but the working angle is 90 degrees. So do not fix your microscope observing through the keyhole. This is the keyhole surgery. So the technical step is to remove the tumor by internal tumor decompression. Marginal tumor margin is retracted toward the base. Then you can obtain enough space of sharp dissection between the tumor and the neurovascular structures. Compressed neurovascular structures may come back to the normal position by this technique. So no danger by retraction of the tumor. So this is after surgery. Even the tumor has the large one, but the attachment is localized. It can be removed by this approach. And this is the maximal size of the attachment by this approach. This tumor extending into the middle fossa and the Meckel cave. But the attachment is from the posterior clinoid to the just middle of all the creeps. So it can be removed only by this approach. So this is after surgery. The not from the postal fossa, but from the Merkel cave. It is removed. So please note, no abducens palsy. This is a different case. The patient had a past history of operation by presigmoid approach. However, only the part of the tumor was removed and transferred to my hospital, and I applied the same approach. However, I did not dare to remove the tumor totally because the tumor had adhesion to the brainstem, because this is the second operation. So radical dissection was depend on the adhesiveness to the brainstem and the invasion into the cavernous sinus. The rest of the tumor was treated by gamma knife after that, and the control. And I'll talk about the some risk of the tumor with thick capsule. If you find the thick capsule on the tumor, around the tumor, it means that most of the neurovascular structures are in the capsule, adherent, severely adherent to the capsule. So do not try to remove the capsule itself. But intracapsular resection is necessary. Do not try to remove the thick capsule. It includes the ICA and the abducens nerve and so on. This patient was a medical doctor, but she could work after operation. And this is a different case, cystic tumor. It is a trigeminal schwannoma. And most of the neurosurgeons may choose a suboccipital route. However, in such a case, the facial nerve is compressed by the tumor posteriorly, so that by the suboccipital route, you may find the facial nerve on the tumor. So I tried to use this approach for this tumor, and the tumor was removed without observing the facial nerve. Facial nerve was left in the posterior fossa. And this is the trigeminal nerve, trigeminal schwannoma. Presented at the first of my lecture. So this patient was very young male, and the ataxia compressed by, the brainstem was compressed severely. So for the trigeminal schwannoma, I do not expose the temporal, but simply I cut the periosteal and expose the tumor. Because the tumor is located in the lateral wall of the cavernous sinus, wrapped with inner layer. So inner layer is thickened by the tumor that separated the cavernous sinus from the tumor. So if you preserve this inner layer, you may not injure the abducens nerve and the carotid artery. You may not open the cavernous sinus. So please note that you can find the carotid artery and the cavernous sinus was preserved. And the brainstem came back to the normal configuration and no injury to the temporal lobe because this is a epidural approach. No abducent palsy. And in the last, I'll talk about the closure. I used a double layer using abdominal fat and the pericranial flap. Closure is very important to prevent CSF leakage. So the first step, I use the piece of abdominal fat placed on the petrosal apex, already drilled off, and coated with fibrin glue. And this mass is covered with temporal fascia and sutured with the dura. It makes a complete closure. So after the 2-layer closure, the incidence of CSF leakage tremendously decreased. So this is the advantage of anterior petrosal approach. Number one, no crossing to 7th to lower cranial nerves. So the risk of injury was very, very low. Number two, easy removal of middle fossa and macular cave tumor. Middle fossa, posterior fossa, both sides can be opened. Number three, early control of feeding arteries. And number four, short operation time comparing the polysigmoid approach, because the resection of the bone is limited and auditory organs are preserved. And what is the disadvantages of this approach? Number one, epidural venous bleeding in patients with sphenobasal vein. I'll talk about later. And number two, difficult learning and difficult performing because this is the keyhole technique is required. Keyhole technique must be learned before that. So I'll talk about the sphenobasal vein. In the common case, the sylvian vein drain into the cavernous sinus. This is a normal pattern. However, in 50% of the patient, the sylvian vein drained into the pterygoid plexus through foramen ovale. And in such a patient, the pericavernous sinus has a thick so venous plexus epidurally, not the subdurally. Epidurally, so epidural elevation may cause the severe venous bleeding in such a case, especially around the foramen, dissection around the foramen ovale. So in such a case, sometimes I use a subdural approach to the petrous apex, but very professional technique. And sometimes I use suboccipital route. So before surgery, please check the venous anomaly in the middle fossa. One anomaly is sphenobasal vein, and another uncommon anomaly is infratemporal vein. So tentorial vein is another one. So such venous anomaly must be checked before surgery of the anterior petrosal pose. Thank you for your attention.
Thank you very much, Professor Kawase, for this illustration of the Kawase approach and its indication. Very clear presentation. Due to the time, I would like to give the moderation over to Professor Vladimir Benish to continue. The next speaker will be on behalf of Professor Fukushima. Vladimir.
All right. Hello, everyone. We have recorded a lecture of Professor Fukushima, which is first like a biography, am I right? A bit, and then a scientific one. So please let's see the recording, this lecture.
We'd like to thank Pablo Gonzalez for helping us in putting this together.
Professor Imato Kanaan, members of the World Federation. I am Dr. Takanori Fukushima, the most senior active neurosurgeon in the world. Every day I work operating about 600 major cases a year. Most of my cases are for difficult and complex skull-base surgery. Thank you for inviting me to present my lecture on skull-base surgery. Over the past 30 years, I have been working very vigorously organizing skull-base hands-on dissection courses about 3 to 4 times a year. Microanatomy hands-on course is extremely important for younger neurosurgeons. They must take 10 to 20 times hands-on courses before attacking the complex skull-base tumors on actual patients. My lecture today is about the less invasive extradural lateral skull-base approaches. Professor, 4 decades ago, in 1980, in Japan, revolutionary changes started from conventional intradural microneurosurgery to the extradural skull-base surgery. Lateral skull-base surgery has been the most important in extradural skull-base surgery. Various innovative approaches were developed in terms of less invasive brain, nerves, and vessels protection. There are 10 different extradural approaches in lateral skull-base surgery. Anterior lateral subfrontal approach, anterior lateral orbital approach, sphenocrinoidal approach, extradural transcavernous sinus surgery, extradural subtemporal ester transrhomboid approach, anterior and middle infratemporal fossa approach, namely AITF and MITF, combined petrosal approach, various kinds of transmastoid exposure, jugular foramen approach, and elite transcondylar skull-base approach. To perform skull-base surgery efficiently with success, one of the most important issues is the use of advanced refined micro-instruments. The number one important is the teardrop side port tapered sections. The surgeon needs 20 to 30 pieces of different sizes and lengths. The number 2 important is the use of 3 major non-stick bipolar forceps, Silverglide, Vesalius, and Tokyo Fujita micro bipolars of different tip sizes, 0.15, 0.2, 0.25, and 0.3 of various angled tips and lengths, 20 to 30 pieces of bayonet bipolar forceps. The number 3 important is the use of 20 to 30 micro scissors, thin blade, medium blade, rigid thick blade, with straight, slightly curved, more curved tips, and of various lengths, short, medium, long, extra long bayonet micro scissors. In this presentation, Fukushima will demonstrate one case of direct cavernous sinus surgery with petroclival clearance and 2 cases of combined petrosal approach. In early 1980s, Fukushima's challenge for direct transcavernous sinus surgery had significant influence and benefit from Professors Hakuba and Dorrance. In 1986, Fukushima published the world's first illustration of the triangular scheme of the entry corridor into the cavernous sinus, later more elaborated in 1991 publication. Fukushima developed the new concept of less invasive transcranial infratemporal fossa approach, AITF and MITF, in 1990, improving the extensive and aggressive exposure of fish infratemporal fossa approaches. V2 and V3 panoramic lateral Vidian triangle exposure for AITF. Fukushima operated more than 100 cases of various infratemporal fossa regions. Meningiomas, schwannomas, juvenile angiofibromas, ameroblastomas, epigonatus, and so forth. Extradural subtemporal middle fossa approach, ESTA, is one of the most frequently used in lateral skull base surgery. In 1992, Fukushima developed the concept of the middle fossa rhomboid while operating the posterior transcavernous approach. In 1986, Fukushima named the posterolateral triangle of the cavernous sinus as Glasscock and the posteromedial triangle as Kawase. The trigeminal third branch anterior translocation has been often used to make access to the infracavernous petrous apex region. The combined petrosal approach was developed in Japan by core members of the Japan Neurosurgical Society, including Fukushima, and utilized for radical surgery of large petroclival meningiomas giant-sized schwannomas, epidermoids, giant cell tumors, chordomas, and so on. Patient positioning is very important, either in lateral or supine heterolateral position. Lumbar spinal shear self-drainage and harvest of abdominal fascia and fatty tissue are standard. Pre-auricular Sheff-Hutt incision, 3-layer elevation of the soft tissue, skin flap with STA frontal branch attached, gyrofacial STA parietal branch attached, wide pedicled, highly vascularized flap, and muscle layers. Understanding of the bony landmarks and the mastoid triangles are the key elements of the combined petrosal craniotomy. At first, the mastoid needs to be skeletonized, either retrolabyrinthine or translabyrinthine. Next, a long L-shaped bone flap is turned, including anterior middle, posterior temporal, occipital, and suboccipital, using only diamondomers and craniotome for minimal bone loss. We never use a big perforator. The dural incision must be only curvilinear, no incision over the vein of Labé. The most important technique in the combined petrosal approach is the detachment and resection of the rhomboid-shaped tentorium. 60-year-old female with very large petroclival meningioma, total resection with fat graft, no deficit. 65-year-old gentleman with dumbbell-shaped large petroclival meningioma, total resection has been performed without any complication. 14-year-old young pediatric large petroclival meningioma, total resection through the combined petrosal approach. No radiation, 10 years of follow-up showed no recurrence. She got married and had children. 50-year-old lady with mega giant petroclival meningioma, total resection with hearing preservation, no deficit. 24-year-old young man admitted on wheelchair with quadriparesis and ataxia. Total resection of the tumor through the combined petrosal approach. He recovered to the normal functioning status, no deficit, and working. Now, video, please.
Enhanced MRI demonstrates a 4 by 5 centimeter size large petroclival meningioma, which is engulfing the vertebral basilar artery. Through a standard combined petrosal approach, the patient is placed in the right side of lateral position. And now this is a right side of the external ear canal, superior point. Here is a root of zygoma, spine of Henry, and we have already performed the retrolabyrinthine mastoidectomy and extended the middle fossa approach. This is the completion of the combined petrosal exposure skull-base drill above, entirely no bones, pre-sigmoid to the jugular bone. Now I open dural, subtemporal, pre-sigmoid. As usual, I'm starting from the backside posteriorly at the junction of the sigmoid transverse sinus. And then now I am incising the tentorium in the posterior side. This tentorium looks no meningioma invasions. And in the depths, I see a big meningioma here. And then I follow anteriorly along the tentorial edge. And I see here the carotid and then oculomotor nerve. And fortunately, oculomotor nerve, the fourth nerve dissections. And this is a posterior cerebral. So I will start from the fourth nerve and the posterior cerebral artery dissection. Now I am dissecting the fourth nerve off from this large fourth nerve sharply with micro scissors and knife. Following the subtemporal ABR, good facial nerve response, and the 5. I am going in the depths between the 7 and 8 and 5. And then I'm pulling all these. Now there are, I find the 6th nerve dissected, and I found all nerves. Only the thing is a vertebrovascular now. Then I separate the abducens. Give me a gel form, please. Now I am opening the Meckel's cave entrance of the trigeminal. Now I opened the Meckel's cave, and this patient is very fortunate. There is no invasion. This meningioma, large meningioma using CUSA. I am now going very effectively to the petroclival origin. And I already separated and this is the elevation of the trigeminal nerve. And I am separating everything from the clivus. And now this, again, using a Olympus ultrasonic aspirator, I am now more decompressing the tumor. Now this is tumor capsule. I am separating sharply. This is the final separation of the main trunk of the SCA. I am getting the last portion of this tumor chunk. Superior cerebella here. It's a main trunk of superior cerebella engulfed in the tumor. Give me a micro scissors. This is a most adherent portion of this tumor with the micro scissors. It's a very fibrous adhesion with the pons. And I have to see the very, very carefully the dissection point. Patient is a 40 years old young lady. I want to make a total resection. This is the last bit of the, I have to separate sharply. Now I have separated the basal artery. It was a very, very severe adhesion of brain stem and tumor capsule. And this side is also the pontomesencephalic junction. And then this is the last piece of tumor. And finally, this tumor I removed in a total fashion. A 6-year-old woman who presented with a 1-week period of acutely progressing headache, nausea, vomiting, and ataxia. The patient has a very large high geography rootlets. This is the ligation of the superior petrosal sinus. And then you see here now, this is the trigeminal nerve root and the tumor, but relatively soft and suckable. You see here now. Now this is the fibrous ring of the trigeminal nerve root. Can separate from the rootlets. Over the tumor, this is the fourth nerve, and using the 11 blade knife, then I cut the into division using a monopolar cautery, a micro scissors straight. I found here the 7 and 8, extremely stretchy, 7 and 8. You see here now. Now I have the arachnoid dissection plane, right abducens nerve in the tumor, and I am following the dissection plane with micro scissors. And hypothalamus and the pituitary stalk. This is the last piece of the meningioma capsule adhesion to the pons, upper pons. After 12 hours of meticulous microsurgery, I finally resected this entirely with this combined petrosal approach.
It's done.
Pablo, that was all?
That's
suppose.
it.
That's it. All right. Thank you very much. That was very nice. And let's say that it was something we all should see and excellent. Next, I would like to ask Professor Mastronardi to give an update on schwannomas. Am I right? Will it be like?
Thanks for inviting me, dear Professor Benes and dear Imad. It is a big honor for me, especially after this huge neurosurgeon that has spoken before me. That's very embarrassing for me. Anyway, I will try to do all my best.
Go ahead.
Yeah, thanks. I try to. Sure. Can you see my slides? Or?
Yeah, just enlarge it for the whole screen.
Now?
Okay, now it's okay. Go ahead, please.
Thanks. This is an update on vestibular schwannoma surgery that I realized according to the Fukushima teaching during the many years. It's disclosure. And this is the philosophy we use when we decide to treat, when we see a patient with the diagnosis of vestibular schwannoma. There are 3 points that we consider every time. At first, the size of tumor, then the age of patient and the general conditions, and the status of the hearing. No doubt that the cause grade 3 and 4, I mean, large and giant tumors have to be resected by surgery. But we have different possibility according to the size and to the general condition of patients. So small tumors, cause 1, cause 2, that are growing and symptomatic in patient in good condition, I usually indicate surgery. But if the patient has very bad condition, I mean, as a 3 or more, probably better to follow him by wait and surgery and wait and scan and then radiotherapy, especially if old patient. But if patient has no symptoms and is stable, surely I don't operate and I wait and scan. If the hearing is preserved in small tumors, if the ASA, I mean the general condition, are bad, better if the tumor is growing, I suggest radiotherapy. But in case that the condition are good, with the hearing quite normal, socially useful hearing, we suggest a total or near total removal. It depends on eventual adhesions, and then in case follow-up. If subtotal resection is necessary because to strengthen adhesion, we wait and follow the patient and redo surgery in case of growing of tumor, or some in selected cases we suggest radiotherapy. So in the majority of cases, we suggest surgery, especially if the conditions are good and the tumor is growing. If the patient is an old patient, I mean, in the 8th decade of life, now it's very common to find patients with diagnosis of acoustic schwannoma at very old age. if the tumor is small and the tumor is growing or patient is symptomatic, we decide to do something, especially if the ESA conditions, I mean, the general conditions are good. In this case, we try to do a general, a microsurgery with gross total or near total removal. But if the tumor is growing and the patient has a bad condition, probably better to send him to radiotherapy. Small tumors without symptoms, wait and scan. Large tumors, of course, we go for microsurgery and with the judicious debulking, especially in relation to the general condition of patient. And in these cases, follow-up is fundamental in order to decide what to do, if just scan or send for the residual growing tumor to the radiotherapy. According to the suggestion of Fukushima, we followed these 10 key points he taught me several years ago. Always operate the patient in a lateral position. I use the retrosigmoid keyhole opening in the majority of cases, only selected cases with the translab approach and the micron technique in all the cases. Before opening the dura, we try to aspirate some CSF from the lateral medullary system for decompress the cerebellum. Then all the time I try, according to the suggestion, to be clean, bloodless, and to do a sharp dissection. A key step is maintain always, when it's possible, the arachnoid plane. And then, especially in big tumors, in large tumors, it's better to do a sufficient internal tumor debulking. Always we try to identify as soon as possible the facial nerve position by monopolar stimulation, and then find and elevate the capsule of the tumor, preserving the arteries and perforators, and most of all, preserving the petrosal vein. This is our series updated to the end of April, 260 consecutive vestibular schwannomas. The diameter in 2/3 of cases was grade 3 or grade 4, so large tumors more than 3 centimeters. The mean age is a little bit over 50, and strangely, but is often found in the literature, the size of tumor was larger in the young cases. The normal facial function at 6 months follow-up was quite high, more than 90% of cases, especially if the tumor was in ventral superior and ventral inferior position. Iris preservation was possible in selected cases with the tumor size lower than 2 centimeters, and especially if the healing was very good or quite good before surgery. This was possible in 61% and more of cases. In summary, our results were presented here. So facial nerve preserved and normal function at 6 months in 90% of cases. Socially useful hearing maintained in over than 50% of cases with good hearing preoperatively. The mean operating time is about 4 hours in the retrosigmoid approach. Very small blood loss and no cerebellar dysfunction in any patient. Only some transient vertigo we observed in 20% of cases controlled with therapy and then disappearing. As we had to, we could follow in the video of Taka Fukushima, the instruments for vestibular schwannoma surgery and for skull-based surgery are fundamental. So we used the thin blade micro scissors, including the Charmant he suggested, the Kamiyama, and many kind of micro scissors, then sharp hook knives, sickle knives, ring and cap curettes, micro ring and cap curettes. So tumor forceps and different knives, sharp lock dissector. Then we use some technology for facial nerve intraoperative stimulation, I will show you later. The ABL for hearing preservation, the Sonopet ultrasound aspirator, and the handheld laser fiber in all cases. Then since a few years, about 5 years, we use the flexible endoscope for the internal auditory canal final check. This is the lateral position that Taka Fukushima showed before, so I can skip. This is our incision. Could be sometimes straight, sometimes curved, but anyway, no more than 5 centimeters long. And we preserve in any case, harvest in any case, a fascia graft for final closure, and realize a 3 centimeters squared craniotomy, exposing the sigmoid sinus and transverse sinus. The dura opening was preceded by a opening of the lateral medullary system in order to have a good decompression of cerebellum. And as you can see in the video, opening this system, it's much easier to cut the dura without any retraction of the cerebellum. We normally cut the dura in a reversal way instead of the classic incision normally used. And this is the final exposure of the tumor. As I told before, the fundamental key concept is to maintaining the arachnoid plane. This is a useful strategy for obtaining the best removal of tumor. Then we try to localize as soon as possible the facial nerve. In this case, was quite easy because the nerve was immediately visible in anterior inferior position because of the small size of tumor. A large tumor, of course, is not so easy. In order to understand which is the most common position of the facial nerve in the CP angle, we tried to recognize it during 100 consecutive cases, and we reported these results on the World Neurosurgery some years ago. In a majority of cases, this positioning is the classic position anterior superior, half of cases. In 1/3 of cases is anterior, ventral, and in 1/4 of cases anterior inferior. In this case, in this series, we never had the dorsal position, but in our updated series, we observed it only in one case, by fortune, because it's the worst condition we can find in these cases. We usually stimulate with the monopolar stimulation from 1 to 5 milliampere in large tumor on the surface of tumor, and on the tumor, on the facial nerve directly from 0.3 to 0.01. In order to identify the capsule and elevate it, we follow the indication of the VCAT suggested by Fukushima, but now we realize this VCAT with the laser. We use normally the handheld thulium laser that is very useful because allowed to cut and to coagulate in the same time, realizing the plane of dissection. We published our experience on this laser in acoustic neuroma, and it was very safe and effective. The opening of the internal auditory canal is another step.
Sonic aspirator.
Very important. These are the landmarks. This is a small video.
The facial nerve that is located
the same case.
anterior. Opening of the internal auditory canal is performed in the first step by means of tritium laser fiber that is used to coagulate dura mater of the posterior aspect of petrous bone in order to detach it and gaining access to the roof of the internal auditory meatus. Second step is the unroofing of the internal auditory canal with ultrasonic aspirator with bony dedicated tips, allowing a gentle shattering of the roof. During this stage, we should keep in mind the fundamental anatomical landmarks in order to perform a safe or preserve the jugular bulb and the labyrinth structures. During this stage, unroofing of the internal auditory canal is performed above dura mater of the posterior aspect of petrous bone that is now coagulated to expose the tumor capsule. After this stage, tumor resection is further performed in the internal auditory canal. Therefore, Additional drilling of the roof of the internal auditory canal is performed, being careful not to damage superior and posterior semicircular canals located in the lateral portion. During this section of the internal auditory canal, low amplitude nerve stimulation is routinely used to detect the facial nerve. Tumor resection is further pursued by means of booklets, curette, and microsurgical scissors. At the end of the resection, a thin layer of tumor capsule is left. More recently, at the end of resection, we performed a short flexible endoscopic inspection of the internal auditory canal in order to detect possible tumoral residue located in the fundus. In conclusion, according to
So after this step, I have to just to consider some key points at the level of the meatus, because the dissection elevation of capsule from brainstem and meatus is the more risky part of the treatment of the surgery. So in this step of the removal of tumor, we normally use sharp dissection instruments like knives and scissors, but time to time we can also elevate with blunt dissection and use the laser as I showed you before. The endoscopically assisted, you had the opportunity to see before, it's very useful, and we published our experience in 2018 on World Neurosurgery again. And this endoscopically assisted removal of tumor in the CT angle showed to be very effective as in checking at the far east, portion of the internal auditory canal if some residue of tumor are still there. And after this, the totally removal of tumor surely enhanced in the years. Again, this was the final check, and some residual tumor was found, and knowing where it is, we remove it safely. And the final check showed the removal, totally removal of tumor. This is the final step. In this step, we will always check the function of the facial nerve, and we understand if the facial nerve responds as lower than 0.2, the function postoperatively is surely normal. We had also a nice experience on the large vestibular schwannomas. We published recently our series of 60 consecutive cases. The concepts are more or less the same, but the fundamental step in this case is the generous internal tumor debulking. And for this, we use the sonopet, laser, and micro instruments. The very important the experience to the setting, on the setting of the sonopet, the best parameters we use now are power the half, suction very low, 5 the minimum, and irrigation 5. In this way, the distress on the nerves seems to be very low. The results are encouraging because in this series we had about 95% of anatomically preservation of the facial nerve. But the final result was good in 72 at 6 months, even if this value is higher if we consider only the cases operated in the last 5 years. Anyway, the results and the surgery is influenced by 2 factors: the adherence of capsule to the nervous and vascular structures, and this was present in about 2/3 of cases, and the hypervascular tendency of tumor, so the tumor to bleeding of the tumor, that was very high, more than half of cases. These are some parameters that seems to influence the postoperative facial nerve function. The morphology, the cystic variant seems to be associated with a worse function. The presence of trigeminal symptoms and preoperative ataxia seems to be strangely associated with a better facial nerve result. The tumor capsule adhesion, of course, and the bleeding are associated with a worse result. And the flexible endoscopy as a better, normally, the use of flexible endoscopy has usually a better function and at follow-up. The position of facial nerve, I told you before, could change from ventral to anterior superior, anterior inferior, or dorsal. Anyway, it seems to be different in cases of trigeminal symptoms or not trigeminal symptoms before surgery. We noted that in patients with trigeminopathy before the surgery, more than 80% of cases had at surgery an anterior superior or anterior inferior position. Whereas in the people without, the patient without trigeminal symptoms, more frequently the position of the facial nerve was ventral. These drawings are taken from the thesis of one of the young staff of my department. This is the thesis that he did for his final graduation as neurosurgeon. And he noted, according to our experience here with our cases, that probably the difference is related to the possible different growth of the vestibular schwannoma. In cases of the equatorial growth on the left side, the facial nerve frequently moves in the ventral position, whereas in the people with the trigeminal symptoms at as beginning or as symptoms at preoperative assessment, this growth of tumor seems to be more polar, displacing the facial nerve at one pole, anterior inferior or anterior superior. Seems that in these cases, this is our experience, the facial nerve is much more protected by arachnoid, whereas the trigeminal nerve is not protected by arachnoid at the level of the root entry zone. And this could justify both the symptoms of trigeminal symptoms and the better outcome of facial nerve in comparison to the equatorial growth. This is just an hypothesis, but we have to verify. It seems to be very intriguing. As usual, the closure is a fundamental step, another fundamental step for the final result. And as told before, we harvested always the fascial graft, and then we put in an underglass shaped way with several stitches. This seems to be like a open umbrella, reversal umbrella. I like to say this because it seems to be that this protection open an umbrella from inside to outside. And after the introduction of this technique, we had very, very seldomly problems of CSF under the wound. At the end, after this stitching, we put some taco seal just for completing the closure. This is the final taco seal plug before to put again the operculum, the bone operculum. Some tricks we use for facial and cochlear nerve preservation, the intraoperative neuromonitoring is of course fundamental for both functions. I told you before about the monopolar stimulation and the intraoperative ABRs. In the postoperative period, all patients received high dose of steroids for the microvascular sampling. Obviously, in some cases, the good sense moved to leave a small millimetric residue of capsule of tumor on the facial nerve or on the brainstem, or both, lying in this case and follow up the patient. The cochlear nerve preservation, when possible, because of the good hearing in the preoperative period and small size of tumor, is monitored in our series with this CCIRP ABR. The CCIRP is a new stimulus that the neurotologists use it for newborns, and is very useful in surgery because it gives the feedback to the surgeon very fast and very affordable. And we can have the answer from the neurophysiologist after maximum 20 seconds of the condition of the cochlear nerve. At the end of any procedure, we use to wash the field with intracisternal diluted papaverine. We had around 100 cases in 5 years. This is not published yet. I would like to wait the 100 case number 100 for making some statistical evaluation. It seems to be a little bit better, but I'm not sure 100% that this is true. Of course, steroids too are used for irrigation, intraoperative irrigation. And since some years, we use also according to the suggestions of the CNS, we use also nimodipine, and we have a personal series of 68 cases with 64 cases with HP1, HP2 at 6 months. These numbers are too small for any statistical evaluation. I wait for big numbers in order to try to verify the real function. So in conclusion, vestibular schwannoma usually requires surgery. Wait and scan in small tumors in old and deaf patients, and very rarely we suggest radiotherapy. This because the total removal preserving the facial nerve is usually possible. And in big tumors, of course, a little bit less, but normally we try to do our best to preserving the nerve. The socially useful hearing can be preserved if maximum diameter is less than 2 centimeters in 2/3 of cases. So my final sentence is that microneurosurgery can cure vestibular schwannoma. And I'm proud to present you the book we wrote with Taka Fukushima and one young fellow, edited by Springer Verlag, with the techniques for advances in vestibular schwannoma microneurosurgery we published just the last year. Thanks a lot for attention.
Thanks a lot. That was really great and very, very educative with minute details about pre or post-op, and the indication chart was very well. We have time for one short question. Anyone?
Please.
Can I ask a question?
Keke.
Dr. Turelier. Yeah.
I see you, Keke. Go ahead.
Do you do a preoperative DTI to identify the position of the facial nerve?
Thanks for this nice question. We just started a few months ago with this technique, so I don't have numbers for presenting this, but I think it's very useful. Yeah, in planning, surgery.
I've been using it for some time, and I find it quite useful. Very, very good.
Yeah. Luciano, one fact I missed. In case of a minor remnant, like a capsule or something, do you go up front with radio surgery or do you wait?
In cases that we follow the patient, of course, so first time at 6 months, then every 1 year. If this residue seems to grow, if patient is young or in good condition, we try to go back with surgery. Only in cases of patients that are maybe with general condition not so good, bad or too old, we suggest radiotherapy. But only if it's growing and the patient is in bad condition.
Okay, thank you. Sanjeeva, I will hand over the chairmanship for you now. Please go ahead.
Vladimir, thank you very much, and thank you for some absolutely amazing talks today. Our next speaker is Professor Volker Seifert, who's the chairman at Maine University, Johann Wolfgang University, I believe, a real expert in skull-base surgery. He'll be giving us a deep dive into decision-making in posterior fossa tumors. And thank you very much for coming to talk to us today.
Okay. Thank you very much. Can you see it?
Yes,
Hello?
we can, Professor Seifert. Thank you.
Yes. Can you see the slides?
Yes, we can. Thank you.
Okay. Thank you very much. Thank you very much, the members of the WFNS Neuroanatomy committee, dear Imad, dear Vladimir, Dr. Ratna, thank you for the invitation. It's a great pleasure to be part of this panel of experts. All of them, I know them since more than 30 years, and we had a great time in this very highlight skull-based surgery, discussed many topics, many occasions. Imad Kanan gave me the topic of complex surgery of posterior fossa, tumors, many tumors, and especially here, the paradigmatic petroclival meningioma. I think we all know, and we already could see this during the previous lectures, and probably will see it also over the next lectures. It's a majority of these complex tumors, as you see here, skull-based tumor, treated nowadays with a high degree of radicality and a high degree of safety for the patient. Petroclival meningiomas, which have been mentioned several times during the previous lectures, still represent a very special entity. And for me, over many years, and sometimes even nowadays, it is something like not only the paradigmatic skull-based tumor, as I think the very complex and very difficult skull-based tumor, but also in many ways, especially in the way of decision-making, talking to the patients. It's something like a neurosurgical enigma. As Imad has asked us to direct our lectures also to the education of the younger neurosurgeons, I think it's quite appropriate to just give a short glance at the history of these tumors. And most of you know this, of course, but it was first described in 1953 by Castellano and Ruggiero in their book on meningiomas of the posterior fossa. And at that time, and with their technical knowledge, their anatomical knowledge, and of course, without very refined neuroradiology, they said that in their opinion at that time, Clivus meningiomas, as they named them, were inoperable. The first big breakthrough came, of course, like many other things, also by Professor Ghazi Yajagil. He published in 1980 in Advances in Technical Standards his book on meningiomas of the base of posterior cranial fossa. And here he described the clival meningioma, as he named them. And he described the growth direction of these tumors and how these tumors could be addressed and could be exposed surgically, altogether with the excellent drawings of his ingenious drawer, Peter Rode. And he stated at the time in the same book and in the same publication that clivus meningiomas in particular have until recent years been uniformly lethal, at that time 1980, in the hand of a very experienced surgeon. The outlook of such patients must be bettered by achieving earlier and more accurate diagnosis, by improving surgical technique, and a better understanding of the pathological anatomy. The first larger series of clival or petroclival meningiomas was by Albino Bricole, published in Neurosurgery in 1993, 13 years after the publication of Ghazi Yajagil, his results. And he stated that in nearly all cases, the patient came out in worse clinical and neurological conditions after surgery than before, and therefore needs constant meticulous assistance. This is already a very strong word of warning in regard to the surgical attack of these very complicated surgical cases. Probably the most important things developed in the next 20 to 30 years and started by the development of surgical principles, new development of surgical principles in petroclival meningiomas, all based on a good and very thorough understanding of the complex skull-based anatomy. This were, of course, Samuel Mefti, Takeshi Kawase, we heard it too in this wonderful lecture, Majid Zami, Ladikim Sheka, and our good friend Ohata, and of course, Takanori Fukushima and Bill Caldwell. They published the first very large series in 1996 of 109 cases. And this probably paved the way for more aggressive attacks on petroclival meningiomas. If we go to PubMed to see how the development in the neurosurgical literature came about, it is very interesting. In the first years, up to the year 2000, there were less than 80 publications, as you can see here. It started a little bit more or less in the years between 1991 and 2000, and then the explosion of publications, scientific publications of the treatment, of the diagnosis, of the anatomy of petroclival meningiomas, especially also in regard to approaches, came in the year of 2001 and 2021. In the last 20 years, 370 publications, which is, I think, absolutely amazing, and it demonstrates the interest that we all had in this kind of tumors. This is my personal series over the last almost 30 years. And I was working at 4 academic institutions, and you can see altogether quite a large number of petroclival meningiomas. But even over this time, there were not more than 6 or 7 petroclival meningiomas a year. Only if you collect them as a series and you have a special interest, you can get enough experience to deal with this very difficult lesions. Quite some patients were lost to follow up. And you can see that there were different treatment modalities used: microsurgery alone, combination of microsurgery and adjuvant radiosurgery, alternative radiosurgery, and observation. I will not go into details about our results. I've presented this on many, many occasions and discussed with some of the experts which are here today and also with others. But it clearly shows that probably surgery alone is not the only way to deal with these patients. And I think one of the topics of my talk is also to open the door for younger neurosurgeons to think about different modalities in a very patient and also very surgeon-oriented way. So I would like to make it quite practical, so I will explain our conceptual thinking in petroclival meningiomas in 7 illustrative cases, which hopefully demonstrate our experiences in some ways and our conceptual thinking in these patients. Now, of course, the first question is always how to approach these tumors. We have seen this in the wonderful lectures by Professor Ohata, Professor Kawase, Professor Fukushima, and I've learned a lot from all of them, especially from Takanori, which is a very good and very long-time friend of mine, and his wonderful surgery had really taught me a lot. I think, of course, the location and the growth direction of a petroclival meningioma clearly dictates the surgical approach. This can be sometimes very confusing. A lot of approaches have been developed over the last years, many of them, and it's quite difficult to understand which approach one should use for a very special tumor or a very special petroclival meningioma. If we go a little bit more into detail, it all goes down to more or less 3 operations. This is the orbitozygomatic approach to those who are primarily in the temporal and in the anterior fossa. I will show case later on. The combined transpetrosal, obviously also one of the workhorse. We have seen wonderful experiences of this and wonderful examples by the previous speakers. And of course, what I probably say, the suboccipital retromastoidal approach, which is in many ways extremely straightforward and very versatile for specific groups of petroclival meningiomas or for specific surgical concepts. This is our surgical approaches in our patients which have treated by surgery. A relative small amount of patients were treated with a petrosal approach. And of course, retromastoid was also my workhorse, and the other approaches were relative rare. I would like to draw your attention also to the possibility of stage operations in of patients when it is really justified to think about this. Our colleagues from Asia here, from India, have said that the retrosigmoid approach is the workhorse for petroclival meningioma. I think so too, because it is extremely convincing, very quick and very easy to do, and you have almost no approach-related complications, which can be very different in complex approaches. And there was a saying, the more the word pre is in the surgical approach, the higher the number of complications. So we also have to think about this, because we should always use approaches as very as very quick or relatively quick and without major complications. This is the first case. This is the classic petroclival meningioma, as you can see here. quite large, 52-year-old male patient, progressive gait disturbance over 12 months, discrete lower cranial nerve affection. If you look at the MRI on the right side, you see there is only a very mild, if at all, brainstem edema. And the surgical approach here was in the lateral position. As you can see, a relatively small opening, and then the removal of the tumor. The difficulty in these tumors lie, of course, in the fact that the tumor is anterior to the cranial nerve. So you have all the time work between these cranial nerves. And during that period, there's always a danger that you put these cranial, very vulnerable nerves to some sort of injury, which of course should be avoided at all costs. This is the post-operative picture. You can see that the tumor could be completely removed, even down to the lower cranial nerves. And we had post-operative a slight facial nerve palsy, a little bit of hoarseness, but otherwise no severe neurological deficits. The patient later on was full-time employed. That's of course a case that we all love, where we can really do very good neurosurgical straightforward work. That's another case. This is also a large petroclival meningioma. Vast majority is in the posterior fossa. The small part is in the Merkus cave and in the temporal fossa. But you can see that there is a massive edema in the brainstem. And you see also that there is a massive vascularization, as you can see here, by the Casanova Berescani, by the very vascularized vessel there that really makes the surgery right away very difficult also to close it before the endovascular means. And this patient was already quite sick. She had a progressive gait disturbance, hoarseness, problems in swallowing, and so on. And here you can see we operated in the semi-sitting position, which I like for many of these tumors using the combined petrosal approach. And when you look at the post-operative picture, you see that it was possible to remove the tumor completely, do surgically a very nice job by complete removal. But as you can see in the lower pictures, the edema increased a lot after the surgery, and there was some injury in the corticospinal tract. Probably we violated one of the very small perforated. And 1 year post-operative, the picture looks much better, but the patient has an extremely stormy post-operative course, which we also must talk about. We only can talk about our successes. Not all of the patients have a good follow-up and have a good post-operative course. Not frequently, especially in clival meningiomas, we must be honest to us, and really be quite clear that sometimes the course can be very, very stormy for the patient. The patient needed 9 months of continuous rehabilitation with then significant improvement. In the long-term run, she had a slight hemiparesis, she's able to walk, and she's part-time employed as a software specialist. So why is one tumor relatively easy? Why is the other one so extremely complicated? And of course, everything in the neurosurgical world can be found in the word Ghazi Yajagi. In volume 4B of his books on microneurosurgery of CNS tumors, he stated that these tumors, and he directed this absolutely to petroclival meningiomas or clival meningiomas, as he named them. These tumors can be accessed, but the biological problem of dissecting the interface between adhesive tumor and vital structures remains paramount. If more radical dissection is undertaken, the consequence is a higher risk of deficits for the patient, in particular oculomotor function and hemiparesis. And that's exactly what happened in the patient, because there was almost no interface between the brainstem and between the tumor. Two more examples to clarify this for the younger colleagues. This is a relative young female patient, slight gait disturbance over 6 months, with great lower cranial nerve affection, quite a large petroclival meningiomas, which has partly incorporated the basilar artery. There is almost no severe edema in the brainstem, which gives me a good idea that we can probably remove the tumor completely without any real difficulties and without doing any harm to the patient. Here we are in the middle of surgery or in the last third of surgery. The large part of the tumor is removed. We are now approaching the brainstem, as you can see here. And if we put some tension along the tumor, you can see that we see and explore very nice fibers, arachnoid fibers. And if we see these fibers, it is relatively clear that we completely dissect the tumor from the brainstem. There is an intact tumor pia brainstem interface. Here you can see the basilar artery. You see the very small perforators coming from the basilar artery. And if you see this also, you can be sure that you will be able to remove these tumors completely by delicate dissection of the perforators from the tumor by preserving the pia, and the pia, especially the pia along the brainstem. That's what we were able to do here. And you see a very nice postoperative result, very small, minor piece left in the posterior part of Meckel's cave, but the patient made a very nice course. And on the long-term run, there was no growth of this very tiny remnant. So this is another case, not very small petroclival meningioma, 60-year-old male patient, again, progressive gait disturbance, slight facial nerve palsy. But if you look at the MRI, you see there is a distinct edema of the brainstem, not very much, but the edema is quite clear. If we look at the intraoperative picture, we are almost exactly at the same area where we've been with the previous patient, but the view is completely different. There is no dissection area between the brainstem and the tumor, not at all. Everything looks like a pot of glue has spilled over the tumor of the brainstem, and even trying to dissect the interface is simply not possible. And you can see that every time I'm putting some sort of stress on the tumor, the brainstem moves with this. This makes it quite clear that the tumor cannot and should not be removed completely. This would bring significant harm to the brainstem and increase the preoperative edema and will result in a complicated and difficult course. Here we are at the end of surgery. We left some part along the brainstem. Here you see again the basilar artery, and you see the oculomotor nerve. This is the image post-operative. You see that we have removed the tumor almost completely, but we left a small remnant along the brainstem, of course, which needs to be observed. But the increase in the edema was not massive, and the patient had, on the long-term run and the midterm run, a continuous improvement of the relatively small preoperative symptoms and deficits. So that's the way to go. And once again, we go back to Yazagil. It is the biological problem of dissecting the interface between adhesive tumor and vital structures remains paramount. How to advise the patient, how to advise the relatives of the patient. Do we have any hint how these difficulties will be? It is, of course, the MRI that shows us some ideas how difficult the surgery will be. And we have good data now from 2 more publications, but these are the most imminent publications on the MRI imaging in petroclival meningiomas. One is from the group of Makoto Nakamura, a teacher of Majid Zami, who was at the time working with Joachim Grauss in Hanover. The other paper, as you can see here, from our colleagues from Italy, and both state that limited resection of tumor may be aspired to avoid significant postoperative morbidity. And the other very readable work by our Italian colleagues says, as a consequence of a tenaciously adherent portion of the tumor, radiosurgery is the best option to treat the residual lesion. I cannot stress this enough, not to overdo the surgical aggressivity, always to think of the patient and to think also patient-oriented. Of course, there are tumors which are large and complex, like this clivus meningioma, which extends down to the foramen magna, which looks very, very adherent. And it must be very adherent because we see the really massive vascularization of this tumor. Is it possible to remove such a tumor despite the possible adherence and despite the MRI picture and the vascularity? This is the intraoperative video. We are on the left side, as you can see. And you see already the larger dissecting. We see the quite large pica, as you can see here. And the problem with those tumors going relatively down is that you have some of the cranial, lower cranial nerves, which you have dissect from the tumor, which very often can result in the passagear lower cranial nerve deficit. The is there is no way to get out of this bleeding because you cannot make a preoperative vascular occlusion of these vessels. All of these vessels are coming from the petrosal dura. The only way is to get to the petrosal dura and to occlude the vessel directly there at the origin. But before you can do this, you have to remove the tumors to reach the petrosal dura. That's what I'm doing here. So you cut out pieces, you accept the vascularity, you accept the bleeding, but you remove them, as some Mefti has said, piece by piece, layer by layer, cell by cell. And now I have reached the petrosal surface, the petrosal dura, and now we can relatively fast occlude the vascularity and then go again to the vessel and to the brainstem. Here we see the left-sided vertebral artery, and we can look over to the other side, see the right-sided vertebral artery, and we see once again that we have an interface, that we have a very good interface that we can dissect microsurgically. That is something that we cannot see before surgery, but it gives us a good chance to remove the tumor completely using meticulous microsurgical techniques. And by this, piece by piece, and then layer by layer, cell by cell, Samuel Mefti, we can remove the tumor completely. Here's the final art, and you see the vascularity is almost completely gone. We just took our time and occluded the petrosal dura, and by this occluding the vascularity. Here's the complete removal of the tumor. We're looking over to the contralateral side, and we can see the abducens nerve there, and at the end of surgery. Now this is before surgery, this after surgery with complete removal. Post-operative, there was a relatively mild to moderate lower cranial nerve deficit, but complete recovery after 6 months, and no other long-term neurologic deficits. This is just to stress that you have not only rely on MRIs or angiography, but you have bring down your decision-making into the operative process and then decide if you would go on with removing the tumor completely, if you see the chance, but if you see that the interface is completely difficult, then you better stop and leave a small remnant and think in a patient-oriented way. Now, of course, we must talk about, if we talk about petroclival meningiomas, we must talk about radiosurgery, of course, not in detail, but we have good data now that radiosurgery in selected patients, which has to be, of course, discussed with the microsurgeon, is an excellent way to treat these tumors. This is the result of the very large multicenter study of our radiosurgical colleagues from the USA. And the results are very impressive, I think. At the last clinical follow-up, over 90% of the patients demonstrated no change or improvement in their neurological condition. That's nothing that we as surgeons can beat if we report our results honestly. Of course, the tumors treated by radiosurgery are much different from those who have treated by microsurgery. They are much smaller, also they are more adherent, but they are much more targeted to radiosurgery than to microsurgery. These are our own results from the Frankfurt Neuroscience Center, our Center for Radiosurgery. We see that our overall local control rate based on the lowest MRI was even higher, 90.6.1%. But even on the long-term run, we see that at 9 years, we have a local control of over 80%. So I think in many patients who are not able to undergo microsurgery, who are reluctant to undergo microsurgery, or whatever reason should be treated by microsurgery, radiosurgery is definitely a way to go. And this should also mean that we should incorporate radiosurgery in our counseling of the patient, in our surgical concept, how to treat a patient. This is a way how we do this, for example. This is a 65-year female patient with progressive gait disturbance, progressive light-sided hemiparesis, progressive oculomotor paresis. She, for the first time, she was bound, and she came with this tumor. And you see the massive compressing of the brainstem, as you can see here. You see the massive edema in the brainstem, and what you can see it, and you see that the basilar artery is completely encased by this tumor. So chances to remove the tumor completely in the age of the patient, of the female patient, are very low, at least to my experience and to my understanding how to treat these patients. So the concept was to remove the tumor as radical as possible without doing any harm to the patient, leaving maybe a small remnant has to be judged intraoperatively. Here's one of the drawings of the publication, the very early publication of Ghazi Yashagil, who had also approached one of his petroclival meningiomas using an orbitozygomatic approach, the same way we have approached it, as you can see. We see the post-operative result. You see, first of all, that the edema after surgery has even increased. Of course, this can be expected, so it took some time for the patient to recover. But you could see here that we could remove almost the tumor completely. We had to left very small area along the basilar artery perforators, which we didn't plan intraoperatively or had enough power to remove it. And I think it was a very, very good decision. Post-operative, we made a classical radiosurgery with a very small amount of radiation to this patient. And altogether, the patient recovered very nicely and is still possible to live a normal and functional life, even with the age now at, I think, 67. Just a few words about endoscopic surgery, which has not mentioned by the previous speakers. It's not exactly the talk of our topics. I went once again to PubMed and looked at the publications. They are very rare, 26 publications up to 2021. And probably the largest was a publication by our colleagues from Japan when they looked at the current status of endoscopic surgery for skull-base tumors, meningiomas. Only a very small, almost going close to zero number of patients could be removed. Most of them were the endoscopic procedure was used to decompress the brainstem. It's almost exactly the same in the last publication of 21 by a very experienced group, Snyderman and Gardner, in endoscopic skull-base surgery. But even with them, radical surgery was in some ways not the standard result of surgery, but anything, it should be, of course, performed in the future and tried how much it can work in skull-base surgery. Probably a better way, Markus Tatajiva from Tübingen has published, is to use an endoscope-assisted petrosectomy in petroclival meningiomas, or use it also in several ways during petroclival tumors, which has published by our colleagues from China in the Turkish Neurosurgical Journal. Let's come back to a staged approach, which has officially published for the first time in 2011 by Majid Zami and his group. And it has opened up the horizon for probably quite promising way of dealing with petroclival meningiomas in a quite patient and surgeon-oriented way. I had the honor to comment on this paper, which was very readable and, as I said, opened the way to another look at petroclival meningiomas. This is one of the publications of Majid Zami here from the publication. You see that they have removed the posterior part of the tumor, compressing the brainstem, and left in place the other parts for additional treatment. This is one of my patients, altogether now 12 patients with staged resection. This was a 60-year-old female pregnant patient with progressive gait disturbance and progressive diplopia. And she told me to wait until birth of her child and then undergo surgeries. And she said to me, you can do whatever you want, but I don't have any complications. from the surgery, which of course makes surgery for the skull base surgeon not very easier. So I decided to remove, looking at the intraoperative way, how to do it, the posterior part, compressing the brainstem and probably leaving the anterior part in the temporal fossa untouched. Once again, here I use the semi-sitting position. As you can see, this is the intraoperative video. I will not go into detail, just once again to have a look at these sometimes truly very difficult and very vascularized monsters. Now, we were able to remove the tumor in the posterior part completely, as you can see, and even down to the meatus acousticus. The patient had a very nice postoperative course and a very, very mild facial palsy, but that's all she had. We followed her up, and it is very important in this kind of approach that you devascularize the tumor completely along the lower part of the tentorium. This, on the long-term run, as I have learned, results in a decrease of the temporal tumor size. And this is the patient after surgery, I think about 1.5 years after surgery. So what have we learned? And hopefully what our young colleagues should learn in the future. Of course, they have to make it better as we do it. But I think now we have a clear understanding and knowledge of skull-base neuroanatomy, especially thanks to many of the previous speakers. We have a routine availability of highly sophisticated preoperative imaging. We have an increased and very good understanding of the tumor-brainstem interface, especially during the recent publications on MRI. Routine application of intraoperative monitoring. We have a routine, but as I would put it, critical use of complex skull-based approaches, increasing reuse of standard approaches, the workhorse idea, at least in my understanding. By this, we have the avoidance of approach-related complications. We have a quite good and increased knowledge of the natural history of and partially operated petroclival meningiomas, which is in many patients much better on our long-term run as we have initially thought over many, many years. I truly believe, and that's the way how I advise my patients, limited, not over-aggressive locality of tumor removal with intraoperative judgment of an experienced skull-base surgeon is probably the best way to deal with these tumors. And finally, incorporation of radiosurgery and stage resection into the treatment concept and the way how we should counsel our patients and his relatives is extremely important. This is not only my idea. When you look at the publications on petroclival meningiomas over the last years, you see that many of our colleagues follow the same way. They say that in 1996, Fukushima and William Coldwell, we are in agreement with others that in avoidance of surgically induced deficit remains a primary consideration. It goes over there where the face of Vladimir Benish is to be seen, that having limited radicality. I personally have said that excellent results can be achieved by tumor control and preservation of life. And Anil Nanda, also a colleague of us, a very good skull-base surgeon with which I have discussed many, many times the treatment of petroclival meningiomas, he said. The author's primary goal was to achieve maximal resection while maintaining or improving neurological function. Our colleagues from India, Suresh Nahia, I know him very well. He's an excellent surgeon, and he has already said the same in 1980, trying to obtain tumor removal, but at a high risk of additional further neurodysfunction is not acceptable in the present area. In 2019, our colleagues from Korea had planned incomplete resection and subsequent radiosurgery is a feasible option for the management of patients with large petroclival meningiomas. And again, in 2019, Hugues Roche, our colleague from Italy, and Bernard, they stated, it's only 2 years ago, not maybe only 1 year ago, optimal subtotal resection of petroclival meningiomas with postoperative radiotherapy or radiosurgery results in long-term tumor control rate equivalent to radical surgery. So if we see these plethora of tumors, it still remains difficult how to treat them and to talk to the patients, to the relatives, and to really find a good concept in any individual patients. At the end, I think we can say that current management of petroclival meningiomas, exemplary, at least to my understanding, demonstrates the shifting paradigms in the treatment of complex clivus meningiomas over the last 3 decades. I think the last publications clearly demonstrate this. Eminent role, there is no doubt about this. Treatment of petroclival meningiomas must be seen within a multimodal treatment context with which excellent results can be achieved. At the end, I would draw your attention to this publication that has been appeared in March 2021 in the Acta Neurochirurgia, also just 1.5 months ago. It comes from the group of Sebastian Fröhlich in Paris, and they have an immense amount of work and put together all the data on petroclival meningiomas and together with the ENS skull dissection. I personally had the pleasure and the honor to be invited to work as external expert zusammen mit Vladimir Benisch, Taka Fukushima, Sam Mefti, Keiichi Ohata, Markus Taitajiba, nur only mention a few. I think this will be a reference publication where everything can be found and which will be valid for many, many more years to come. Thank you very much for your attention.
Professor Sefer, thank you very much. That's an excellent talk, a fantastic systematic review and very honest review of the problems we face in this difficult pathology. I think we have time for one comment or question. Does anybody want?
Yeah, I make a comment.
Yeah.
Professor
Volker,
Bennett and then Dr. Zhao. Yes.
Volker, this is Keki Turel. Thank you very much for this very nice update. My question is, if you see a young patient with a smallish tumor and no neurological deficit, what would you do? Would you prefer to observe, or would you prefer to operate and excise it completely? Young patient, practically no deficit, or incidentally?
Yes. That's one of the questions we love every day in our outpatient department, if you see such a patient. If it's a young patient or if it's an older patient whatsoever, and he has absolutely no signs, just without any problems, without deficits, I would just stop and observe him. Because the long-term run of these tumors is completely unpredictable. I've just had seen a patient from the Netherlands, which had a very relatively small tumor, which had been treated by radiosurgery 25 years ago. And the tumor had become a little bit smaller, no signs of growth. So it's quite unpredictable. Very often I see patients, much more often than younger patients, I see older patients, 65 years, 70 years, sometimes 75, with large tumors without any symptoms. I have patients who are coming from the golf course. They come with the proposal by a neurosurgeon to have this tumor removed. And I think this is something we really must think about. If we would advise our relative, our wives, our friends, whatever, if they should undergo a surgical removal in a tumor without any problems. Many of these patients I can observe over several years, and even with 75. I have patients who have become 83, 84, 85, and the tumor remains almost the same size. If the patient has no symptoms, I think it is absolutely justified to wait. If the patient has symptoms, of course, then we have to go ahead. No doubt about this.
Thank you very much. Vladimir.
Yeah. Volker, I always enjoy the lecture on petroclival by you, because it's so reasonable and so logical that there can hardly be said anything. I just would have one technical remark. In all the tumors which are above the level of the meatus, I use the supracerebral infradental approach. And the advantage is that very early on, I cut the tentorium along the medial border of the tumor. I have very good control of the superior cerebral artery, very early control of the third nerve. It's very easy to resect the subtemporal part of the tumor, but most importantly, as soon as you push the tumor a little downwards, you very early on in surgery see the interface between the brainstem and the tumor, and you just go downwards. Very easy, very straightforward approach, which gives you more space than a regular retrosigmoid.
Yeah, you're right. There's only one point, and I completely agree with you. We also have these tumors, but I completely agree. But these tumors who are located above the level of the meatus, they are very rare. And we see them sometimes when they are very small, then they are very difficult because there is no space to deal there. It's difficult. If they are large, they are very, I have only a very small number of patients in which the anterior part, rostrally, of the meatus is very large. If this is the case, then I would completely agree with you and would use the same approach. But many patients, the tumor goes down at least to part of the lower cranial nerves, and then you have to, of course, to use the classical approaches, at least one of them.
Sure, you can even combine it.
Yeah, of course, you can. Yes, you can do this. But it's a good addition of the standard approach. I completely agree. Yes.
Thank you.
Thank you very much.
I have one question. I want to play the devil advocate on this subject. Now, you said if you have a young person with asymptomatic, but you have a small petroclival or meningioma accessible, and you are sure you can achieve a good resection. I think maturity and age they push us to a more conservative line of management. 10 years ago, 15 years ago, perhaps we don't say this statement, isn't it? This is over the practice and the experience. Now, there are many tumors, they are unpredictable, yet we tackle them when they are in young people, because you give a time span for these to become a difficult surgery. I mean, if you can go, if a tumor is above the meatus and you have a good access for complete resection with a very good outcome, why we should defer it? And with the potential, it might grow up, adhere, and it make a less complicated procedure and more difficult. I know this is unpredictable unless you tell me you are going to check 1 or 2 years and see the trend, how is they are growing. If there is a sign of growth, then you will go after. So what is your take on this?
Yeah, I think the answer is relatively straightforward. Of course, if the patient, for whatever reason, requests the surgery, of course, we can do this. On the other way, the main reason is, even in these cases, we don't have always patients who come out of this kind of surgery in a very good way. Even then, you can have problems. And if this is a 35-year-old female or a male patient, fully employed, very active, and you must have a good reason to send him to surgery, because nowadays we're living in the time of MRI. You can make an MRI every year or every several months, whatever you do, and you see if the tumor starts growing, the thing is changing completely. But if the tumor stays completely stable, why would you expose the patient for a possible, not infrequently, even in some ways, dangerous surgery? It's very difficult. Not my daughter. My daughter is 34 years old. She is a doctor. If she would have such a patient, I would say, just wait. We can wait. We would see 2 millimeters, 3 millimeters. We see on the MRI. If this is the case, then she will have to undergo surgery, radiosurgery. But without any symptoms, at the first, we see many patients coming from outside with the first MRI showing a petroclival meningioma. It's the same with a patient with a 4 millimeter or 5 millimeter aneurysm. The literature is quite clear for this. There is no scientific reason for her to undergo surgery. At least this is my opinion. I know some very experienced skull-based surgeons who have the same opinion, but it's a matter of discussion, of course, absolutely.
It was not the consensus, I imagine it's not the consensus on that paper published by all these names.
This skull-based European skull base paper.
When I saw Sam Mufti and others on this paper, are they agreeable to this approach?
No, this is no. This please read the paper. You get it there. It's about everything. It's about the radical surgery. It's about the waiting period. It's about the stage surgery. Everything is put there. So you found everything there. This is not a consensus approach. The consensus is that there are different options, different ways how to treat these patients. And that's why even someone like Sam El-Mefti, who I admire very much and I really adore him, but even someone like Sam El-Mefti, who does surgery in the vast majority of his patients, agreed to this publication. It's a very diverse publication, very readable. All aspects are covered here.
We have forgotten one aspect, Volker. We have forgotten the hormonal treatment in women between 50-60. Quite free. We all know the relation between the pregnancy and meningioma, that they can compensate. And if you get a patient, female patient who is 50-55, treated by the gynecologist by hormones in their menopausal time, she's oligosymptomatic. You take away the hormonal treatment and suddenly the lady is without any problems and you may observe the tumor.
Absolutely. I mean, you are some of the advisors of this ARNS paper. And of course, this is also covered there. But I would not cover this aspect in my surgically oriented lecture.
Right.
Thank you very much. Thank you again, Professor, for an excellent presentation and stimulating a fantastic discussion. Thank you.
Thank you very much.
If that's okay with Vlad and Imad, we'll move on now to Professor Bill Culver from Utah, a real expert in skull-base surgery. We're taking a slight change in topic now, away from the petroclival region into an area where he's a real expert in orbital tumors. Professor Caldwell, thank you for joining us today.
Well, thank you very much. It's an honor to be here, and I want to thank our hosts, Vladimir and Imad, and also Pablo for setting this up. I think it's a great event, and it's really an honor to be involved. Can you see my slides okay?
Yes.
Great. So we're here to honor Shigi Kobayashi, who's made some really seminal observations in aneurysm surgery, and congratulations, Shigi, for all your lifetime achievement in this area. Takeshi Kawase, who recently received the Golden Neuron Award from the World Academy. Here's a picture of him in our home in Utah some years ago. But congratulations, Takeshi, for your contributions to skull-base surgery and to vascular surgery. And one of my personal mentors, Taka Fukushima, 30 years ago this year, he and I spent 2 years together in Southern California, and I'm really indebted to him for all the time that he spent. And he was a surgical master, and he's still pushing the field today. So congratulations, Taka, well-deserved. So this is Utah, and it's interesting because we have a huge, it's not a really largely populated area, but we cover a large geographic area. And it's interesting, let me show you this case. So this is a case of adenoid cystic carcinoma, but she came from Montana and she lost her vision 2 years previously, but never went to a doctor. But only when she started to lose consciousness and become really comatose, then she was brought in emergently. And I emphasize this case because, you know, with the skull base and these tumors that are not common, and we have to rely on experience of surgeons to help identify the way forward. Just as like in the petroclival talk, we just talked about the nuances of surgery. We don't have class 1 or class 2 evidence to demonstrate what we should be doing in any of these diseases. So we have to rely on experienced surgeons to give their benefit of experience to the younger people. So I would say that one of the new frontiers that we as skull-base surgeons need to really be much more familiar with is orbital surgery. And I'm really indebted because I work with a great oculoplastic surgeon Bhupi Patel, and we've done a lot of work together ourselves. And, you know, a lot of the disease that we take care of as neurosurgeons, meningiomas, for example, skull-based tumors, they involve the orbit, and we shouldn't be timid about going in and removing them. The anatomy is not that difficult, and you need to study this in the skull-based lab. But the relationship of the nerves at the superior orbital fissure is important. These are beautiful dissections of Roten. But the third, it gets crossed by the fourth nerve at the superior orbital fissure. And if you see in general, the nerves and the arteries and the veins come in laterally and then swing medially. And you'll see that with the ophthalmic artery. You'll see that with the superior ophthalmic vein. You see that with the fourth nerve. And you see that with V1. Here's the first division of the trigeminal nerve, the supraorbital nerve. And it's important to recognize this anatomy because it's covered in fat often when the tumor, but it's a forgiving area to operate. You need to understand the innervation to the muscles, and that's beyond this lecture, but it's important to recognize that the anatomy is very, very easy to master, and the orbit is a very forgiving structure to operate. And the techniques that we use intracranially translate nicely into the orbit, use of our retractors, and I'll show you that. So we wrote this review on orbital surgery, and you can use the orbit, of course, as an access to other aspects of the cranium, supraorbital porch, for instance, or you can go and address pathology within the orbit itself. And I look at it fairly simple. If the disease is involving the orbit laterally, superiorly, we'll come in with a transcranial approach, whether a lateral orbitotomy approach or a mini-terional or a supraorbital craniotomy. And if the disease is involving the medial and the inferior aspects of the orbit, the transfacial approaches are beautiful. Endonasal. You can take the medial wall of the maxilla down, and I'll show you that, and you get a beautiful view of the inferior and medial orbit. So it's important to learn these techniques in the skull-based lab and then translate them to disease. Here's a hemangioma of the orbit in a middle-aged man. He's losing vision. He's got some proptosis here, you can see. And what we'll do is we'll do an endonasal approach where we'll combine it with a transmaxillary approach. So middle turbinate, we'll resect that, and then expose the maxillary sinus as well, and combine it with the nasal cavity into one cavity. And then you get a beautiful view of the inferior aspect of the orbit. So here's the orbit coming into view. This is a tissue debrider, it's very handy. And here's the inferior medial orbit. Now you'll see the technique that we'll use is exactly similar to removing, say, an acoustic tumor. So we'll debulk the center, and then we'll find the margin and then bring the capsule in and dissect the capsule from the periorbital fat. This is a hemangioma, so it's quite vascular, and it's attached by a vascular pedicle. And we'll go ahead and remove the hemangioma and then cauterize the pedicle. And then once you cauterize the pedicle, you'll be able to remove it. And there you have it. Now, there's no significant closure for a case like this. The periorbital fat is herniating somewhat, but with this amount of opening, we wouldn't reconstruct the orbit. And it's a very simple operation. And you can see his post-op scan, and he's got now reduction of his eye, and his vision was normal. His optic nerves decompressed. So the other thing is that there's tumors involving the superior aspect of the orbit, and you'll have to choose the approach that you want to achieve to remove it. So here's an interesting case. Here's a V1 schwannoma just above and medial to the optic nerve. So in this case, we'll come in with a transcranial orbitotomy. It's a simple operation. We're all familiar with this. It's all extradural. We'll remove the orbital roof and then find a window into the tumor. Now, this is the levator muscle right here. And what we'll do is we'll make our window over the region of the tumor and then open up just medial to the levator. Now, the levator is innervated by the superior division of the third nerve in the orbit coming inferiorly. So this is a safe way to mobilize the levator. And we're right on the tumor now. And this is just like a trigeminal schwannoma anywhere else. We'll open it up and we'll, this was partially cystic, so you'll see we'll drain into the cyst in the tumor. But we'll then decompress the tumor. There's the cyst drainage, and then remove the tumor using our same microsurgical technique that we would use anywhere else in the cranium. And there's the tumor. We're lifting it out of its investment. We use these soft cottonoids that were developed many years ago when Fukushima and I were together in Southern California. And then remove the tumor, and then you'll see the closure. Here we got into the frontal sinus, so we'll put a pericranial flap over for closure to prevent a CSF leak. And then go ahead and close the craniotomy. We use MedPOR cranioplasty. And now these tumors are very interesting. Sam Al-Mefti and I just published this series of these interesting trigeminal schwannomas. And let me show you this case. This is a 22-year-old woman with proptosis of the right eye. And if you look at the tumor, it's a skip lesion tumor. So it's involving the cavernous sinus here. And it goes right out V1, all the way out to the superior aspect of the orbit. And it's causing proptosis. And we had a series of these patients that have skip lesions. So there's parts of the nerve that are normal, and then you go further out and the nerve is involved. And Sam and I both put a series together and just published this recently. But what we'll do here is we'll combine, we'll do an orbital frontal craniotomy. So you can see we're including the orbital rim with a frontal craniotomy here. So this will enable us to address the tumor in the orbit and all the way back to the cavernous sinus. So here, Bhupi Patel is dissecting the tumor from V1 in the orbit to try and reduce the mass that's pushing down on the globe. And you just march back. Remember, V1 is the most superior structure in the orbit. And we'll de-roof the medial or the lateral and the roof of the orbit, and then go right back and do a Dolenk approach to the cavernous sinus. So I'm peeling up the lateral wall of the cavernous sinus now, and we'll find our window into the tumor. And you can see it's hemorrhagic. It's in this tumor. You can see it as evidence cystic areas and bleeding within the cavernous sinus. And it was beautiful shown by Ohata earlier and Dr. Kawase that you can just stay within the tumor and you won't interfere with the abducens nerve. Now we'll follow the tumor all the way out along V1 through the superior orbital fissure right up to the superior and anterior aspect of the orbit. And parts of this nerve are completely normal and parts of this are completely involved with tumor. So it's very forgiving. The fat is your buffer to the optic nerve and the globe. So there's this cystic areas in the tumor and this nuggets of tumor along the nerve, like a pearl necklace all the way along. So at the end, we just close and you'll see the post-op scan here. She's got reduction of her proptosis, and I've followed her for many years now. And she's done very well. So the other aspect that we need to talk about is when these meningiomas involve the sphenoid bone, because here's a classic case, and I'm sure you see this all over the world, is that the surgeon takes out the middle fossa tumor, but the patient has proptosis and the proptosis gets worse And in this case, it's hyperostosis from the sphenoorbital meningioma. And this is a very profound example. She's from Eastern Europe, and she was in extremis when she came in. But you can see the amount of proptosis that can occur. Here you see tumor in the orbit. She's got hyperostosis of the bone. She's got tumor in the middle fossa. She's got tumor extracranial in the temporal fossa and in the orbit itself. And what we do in this case is we remove all the bone that's involved. Sam El-Mefti and others have taught us that the bone that's thickened is tumor, and you need to remove it because it's causing the proptosis as well. Now, in most cases, the rim itself is not involved with the tumor. So it's actually very convenient because you can leave the anterior aspect of the orbit if it's not involved, and it's your cosmetic landmark. And then you can remove all the tumor in the bone posterior to the orbital rim. So I started doing this operation about 20 years ago now, where we've removed all this. This is a classic case, somebody who had a middle fossa meningioma, recurrence in the sphenoid bone, terrible proptosis. These people are congested, they have chemosis, they have difficulty with a dry eye. And what we'll do in this case is remove all the bone. And you'll see now the eye is reduced. And I'm going to show you this very dramatic case from this woman from Eastern Europe. And you can see she was herniating on the scan. Here's her temporal horn that's trapped. She's got lots of edema in the brain. And we did her urgently. And so we'll do a frontal temporal craniotomy and all the bones involved. So you need to drill through this. It's very thick. It can be an inch thick and very vascular. And we'll spend a lot of time doing the drilling. It's a little bit like archaeology, trying to find normal anatomy. And so here's a very thickened clinoid. And we'll remove the lateral aspect of the orbit. This is a superior orbital fissure we're coming upon. And I just want to point out there's all tumor in the orbit here as well. So after we remove the clinoid and decompress the optic nerve, we'll remove the tumor in the orbit itself. And so the rest of the tumor, this is coming off the medial and the frontal lobe and the temporal lobe. But I want to show you the part in the orbit itself. So we start just behind the orbital rim, and you find the interface between the tumor and the periorbita. And then you stay on that interface and just dissect back. In most cases, the muscles are not involved, but occasionally they are. And you'll have to decide whether you're going to sacrifice the muscle for tumor control. But you follow it posteriorly, use your retractor, and then go right back to the region of the annulus of Zinn. And you've got to be careful at the annulus of Zinn, because you'll interfere with the muscles that attach at the annulus and the superior orbital fissure. In this case, the superior orbital fissure was not involved. So I used to reconstruct the orbit. I've stopped doing that now. And the simple reason is if you reconstruct the orbit, you won't get reduction in the proptosis. So we brought her back for a cranioplasty, but I just want to show you this scan. Look at the amount of reduction that she's achieved. Look at the optic nerve. It's like a road course now. And that would not be achievable if you reconstruct the orbit. And I'll show you why when I show you our data. So we brought her back in 2 weeks, put a cranioplasty in because all the bone was involved, obviously. This is a custom cranioplasty. And after the cranioplasty was in, I'll show you her face. And you can see here's the pre-op and the post-op, and she's had excellent reduction. So this is what I've come to with these tumors. I've become progressively more aggressive with removing them. Now you'll say, well, you must have caused an enophthalmos, but I would like to differ with you on this, because if you look at the bone removal, so if you look at the proptosis before surgery, and this is just comparing the length of the orbit and the optic nerve to the globe on the affected side versus the non-affected side. If you follow this over time, none of them became enophthalmic. And in fact, I had incomplete reversal of the proptosis in many cases. So don't be afraid. You won't cause enophthalmos. It's a completely different disease. If you take a normal orbit and you decompress it, you may very likely have enophthalmos. But these people have so much disease around the orbit that the globe does not overcorrect when you leave the roof and the lateral wall off. We use a very aggressive approach in these tumors to try and reduce recurrence and take away all the bone that's involved with the tumor. So this is an interesting story because Yazırgil was the one that started us thinking about this. I had a Turkish fellow, Tamer Altay, who's back in Istanbul now. And we wrote this paper on the evolution of the terional approach. And if you look at this, it's quite interesting. The first use of the term terional was in 1964 by Hamby. And the reason for the approach, and Yazırgil was the one that really popularized it, was, as you know, prior to that, the subfrontal approach was the approach of choice to the suprasellar cistern. And if you come farther laterally, it's a little bit shorter, and then you can look behind the optic nerves and you get control of the carotid. And it was popularized by Yazırgil with his approaches to the anterior circulation aneurysms and the basilar apex aneurysms in the 60s. But it occurred to us that we could evolve the approach a little bit more. And if you have these cancer cases where you know you're going to do an orbital exoneration, you can actually get a beautiful view of the cavernous sinus. So if you're going to remove the region of the orbit, it gives you a direct view without touching the brain of the cavernous sinus. This is the anterior loop of the carotid right here. And you can see that it's very, very well tolerated, and the patients have no brain retraction when you do that. So you can come down the lateral aspect of the orbit and reach the cavernous sinus. This is an approach that was originally devised and used for lateral approaches to the orbit by the ophthalmologist, but you can extend it intracranially is the point. And this was published some years ago, but you can use it to address a pathology both in the orbit, in the superior orbital fissure, in the cavernous sinus, and the middle fossa. Here's an example. So this is a 70-year-old man with visual loss, and he's got compression of his optic nerve by cavernous sinus meningioma, and we're doing a clinoidectomy here and decompressing the optic nerve.
We then see exposed the lateral.
So this gives us a beautiful view to the cavernous sinus and the optic nerve region. And we'll do this for limited approaches to this area. This is what you see post-op. This is the incision. We use a lateral orbitotomy incision here, and there's no temporalis wasting. We've done hippocampectomy on one patient, hemangioma, so we're addressing more lesions of the brain now through this approach because it's a direct view. Actually, it's a perfect access down the hippocampus to be able to do a hippocampectomy. I won't show you this for time, but we have modified it a little bit. We use a little smaller opening, and we leave the orbital wall completely intact so we don't have to fight back the fat and fascia. Let me show you this case, because this is a case that I want to actually acknowledge Sam Melmefti on this, because he's the one that really promotes taking a look in the cavernous sinus to see if something's resectable. And I'd like you to think about this patient, because what would you do with this patient? 14-year-old girl, she's got this little tiny lesion here in the cavernous sinus. So I thought this was going to be a schwannoma. She met with several different surgeons, and most people just wanted to radiate it. But she's 14 years old. She's got a progressive third nerve palsy. So in this case, we'll do a lateral orbitotomy, and I'll show you how we'll address this tumor. And some of these tumors, I think, should be explored. And I've actually become more aggressive at exploring some of these tumors, not necessarily removing infiltrative ones, but taking a look through a surgical approach. So lateral orbitotomy approach, cavernous sinus, lateral walls being peeled up. And you'll see here, we're right on the fifth nerve. So we'll use image guidance. We're at the superior orbital fissure there. Address the fifth nerve. Now, what you'll see here is I'm looking around for the tumor. And it's very discreet. It's tough and very discreet. and you can dissect it around it completely. This was a meningioma. It was not a schwannoma. And some of these meningiomas in this location are not infiltrating the nerves or the dura and can be removed. So here we're removing the meningioma between the third nerve and the fourth nerve. And we're able to get a good removal from the region of the superior orbital fissure and the cavernous sinus. So in younger people, I think it's worth taking a look. I only operate on symptomatic lesions. Obviously, we don't operate on incidental meningiomas, as we follow the course exactly as Volker described. But this young girl was losing vision. So it's all extradural approach. There's no dura to close. We replate the orbital rim and go back and then close it with a subcuticular suture. So we followed her now, I think for 3 or 4 years. This has been a published case, but she's had no recurrence, and her third nerve has actually gotten better. So and finally, I'm going to leave you with this because I want to show this case because this is a neurosurgical disease extending into the orbit, a classic neurosurgical disease. And this often is done through a 2-stage approach. But this is a woman who's blind with a optic nerve glioma. And we're just publishing this approach, but you can do this in a 1-stage, and we're going to show you how to do this. Traditionally, it's been done by 2 stages, a transcranial approach to cut the optic nerve in front of the chiasm, and then another approach to come in superior to the orbit and cut the nerve behind the globe. And we're going to show you how you can just walk out the nerve right out to the globe. So she has a non-functional eye. This has been biopsied by the ophthalmologist. It's a low-grade glioma. And since it was progressing, we decided to remove it to prevent the tumor from spreading to the chiasm and involving the other optic nerve and chiasm. So frontal temporal craniotomy. Orbital band, which is cut and dissected down to expose the clinoid. We then drill the lateral and the superior orbit. Periorbit is identified and is left intact at this point. We then unroof the optic canal and identify the optic nerve. After exposure of the superior orbit, we continue our removal of the roof to the level of the globe, and then remove the anterior clinoid process. After drilling the optic strut, we loosen the clinoid, which is removed. The carotid is identified. We then open the dura in a T-shaped fashion, following the sylvian. The chiasm is identified. We'll then plan to divide the optic nerve approximately 2 millimeters anterior to the chiasm to respect von Willebrand's knee. After the optic nerve is transected, we then open up the falciform ligament and follow the nerve within the canal. The annulus of Zinn is identified. We will then open up medial to the levator palpebrae, taking care not to injure the frontal branch of V1. We then identify the proximal optic nerve in the orbit. Cranial nerve 4 is identified exiting the annulus of Zinn, and we'll dissect immediately on the optic nerve, which is thickened in this case. The nasociliary nerve is identified crossing the optic nerve. We then continue our dissection on the optic nerve using self-retaining retractors to hold back the periorbital fat. We then identify the region of the optic nerve that was biopsied previously, which is very scarred.
and we approach the globe. The nerve is then transected just as it exits the globe. We then elevate the nerve and free it of its investments and dissect it back towards the annulus of Zinn. Now, the key step in this procedure is to gently dissect the nerve from its investments within the annulus of Zinn without interrupting the nasociliary nerve or the fourth nerve. We're able to remove this as one specimen from the chiasm to the globe. We then close by reapproximating the annulus of Zinn and reapproximating the periorbita. Of a defect.
So
this case,
I think it's important, and I'm going to show you this last case for us to be shepherds of the disease. And what I mean by this may be an American phenomenon, but we see this quite frequently, where these meningiomas that are involving the orbit are insufficiently treated with surgery and then create larger surgical problems down the line. Quite similar to what Imad Kanan was talking about with small petroclival tumors. So you have a middle fossa tumor that's now involving the orbit, and it has insufficient surgery and it's now in the orbit. 3 times they have orbital surgery, but it's not removed. They try to preserve the vision, and now she's lost her vision. It's involving the cavernous sinus and threatening the other cavernous sinus. So in some of these cases, we'll be aggressive. She was sent to me for a salvage surgery at this point. She's had radiation. And we're left with a situation where it's very difficult, and you need to be very familiar with the orbit. It's a simple case in this case, because we're going to actually just remove the contents of the orbit. She's got a prosthesis in here, and we'll just go ahead and remove that. And then you can come around the contents of the orbit. Most of the blood supply is coming through the ophthalmic artery to this tumor that's occupying the entire orbit. So you just ligate the ophthalmic early on, and you'll save yourself a lot of bleeding. And then the tumor goes down into the face, and we'll chase it down into the face. This is very forgiving. You're lateral to the facial nerve. You've removed the contents of the orbit, and it's a fairly simple matter, and we'll go ahead and remove the facial tumor from above and chase it down to the region of the maxillary sinus and the pterygoids. Now, obviously, this tumor has been radiated several times, so you're going to need decent closure. And so with our head and neck colleagues, we'll use a fascial allograft and also a thigh free flap to close. Otherwise, you'll be fighting CSF leaks because you're going to lose such a big defect and create such a big defect by removal of this tumor. So we'll place the free flap in from above, and then you'll see us revascularize it from the external carotid artery. Now, she passed her balloon occlusion test, so we didn't need to bypass her, the internal carotid. So all we had to do was just ligate the carotid intraoperatively. And on the upper film, I'd just like to show you, here's the middle cerebral artery stuck to the tumor that's growing in the face now. And so you've got to be very careful and preserve the en passage vessels, yet devascularize the tumor to be able to remove it. So once we get the tumor disconnected from the brain, there's the optic nerve. We'll go ahead and ligate the carotid and the optic nerve as well. And as I said, she passed her balloon occlusion test. So this is the type of surgery that these cases require once it involves the cavernous sinus. And here's her post-op scan. And she's done very well post-op. But I think this is a case of insufficient surgery, and we need to really be shepherds of the disease so that we think about tumor control and not just preserving function at all costs, because once the horse is out of the barn, then it's very difficult to manage. So I encourage all of the younger neurosurgeons to think about operating in the orbit, and I thank you very much.
Thank you for an excellent presentation there. We're at the end of the session, but we have time for comments or questions. Does anybody have any comments or questions?
I have a comment.
Well,
thank you very much for a great presentation. Thank you, Keki here.
Good to see you, Keki.
So, thank you. So you showed us a variety of pathologies. What you did not touch is optic sheath meningioma.
Yes.
What's your take on that?
Yeah, no, I agree with you. That's yeah. So yeah, for the younger people, these are really problematic tumors. So I'm very aggressive, Keki, up to the region of the canal where the nerve sheath attaches to the nerve. Okay, you open the falciform ligament and you dissect the dura off of the falciform ligament off of the optic nerve. And then once it's stuck to the nerve at that point, I amputate. And I have not gone in. I know Sal Mufti has published a few cases, and I'd like to hear other people's experience. But we have not gone in and tried to peel the meningioma involving the sheath off the nerve. We have not done that. We usually radiate those patients, and then if they lose vision and they've got a mass, then we'll just do exactly what I just showed you. We'll remove the nerve and the tumor. But I have not tried to remove an optic nerve sheath meningioma because I'm worried about devascularizing the nerve. But I'd like to hear other comments.
Bill, I want to ask you another question about hemangiomas, cavernous hemangiomas.
Yeah.
I want to know, you mentioned about hemangioma and about the bleeding and about the pedicle and all those things. What do you when I see hemangiomas involving orbit, they look like completely different beasts when compared to cavernous hemangioma involving the cavernous sinus. What is your take? What do you think about the vascularity? Some of these hemangiomas in the orbit, I find them completely almost, they can be taken off like a placenta, slip off from the orbital contents. And vascularity is not exactly very heavy when compared to hemangiomas in the cavernous sinus. I want to know about what you think about hemangiomas.
Yeah, so that's an excellent question. And it is true. There can be horrendous bleeding from these hemangiomas in the cavernous sinus, as you know, and they can actually extend. I have some of them that have extended into the sella from the cavernous sinus. So I've actually mistaken a couple of them for pituitary tumors initially. But they can be very vascular, as you know. The ones in the orbit are quite benign. I think they're quite simple to remove. That one was very simple. So that's not really a challenge. I think the point I was trying to make is that the skill set that we use in intracranial surgery is very well founded to address orbital disease. And I think we're doing this much more frequently than the ophthalmologists do it. And I find it very helpful. They're helpful for the basics of the orbit, but actually removing the tumor, I think it's really in our wheelhouse, and then we should be more aggressive and teaching our residents to not be intimidated by the orbit. It's like the facial sinuses were a generation ago but we mastered that in no time, with transfacial approaches. And I think that we should be addressing disease in the orbit. I see most of our facial plastics people, there's only a few of them that are really involved with removing tumors and such. It's a real minority of the eye doctors.
Another thing, Bill, is the recent thing with COVID and corona infection. Infection of mucormycosis in India following corona viral infection and indiscriminate steroid use has led to mucormycosis in India in a very huge way. And mucormycosis has been involving the orbit, cavernous sinus, and paranasal sinuses. Do you have some experience with the mucormycosis in particular?
Yeah.
And also infection in general in orbit?
Yeah, we've dealt with this. In fact, I think one of the early case reports that we did of of cavernous sinus resection was a Mucor patient. And he'd failed treatment with antifungals. He was on amphotericin for a year or two. And we actually have a series of fungal sinusitis patients that we manage. It was published some years ago now. But yes, I haven't seen, I must admit, a tool. That's the first I've heard about Mucor increasing during COVID. And that may be true. We see it in diabetics here, and it's a terrible disease. And it marches up the sinuses into the cavernous sinus and into the eye. And we've had to resect the posterior orbit and the cavernous sinus in a couple of different patients. I had one patient too, I just want to warn people about. So I had a cavernous sinus involvement from Mucor, from the carotid was being involved, and the carotid was starting to thrombose off. And so we bypassed this patient. It was left-sided cavernous sinus infection. And I bypassed the patient with a high flow bypass. And when I opened up M2, all the anterior part of the artery was like cheese. It was all disease that was way beyond where you could see it on the scan. And I knew that the bypass was going to be threatened. And so I did the best I could. I did a partial endarterectomy and I sewed the graft in, and we kept him on high dose aspirin. I left him on a little heparin post-op, but 3 days later, he lost his graft and he died. So that is a deadly disease when it involves the arteries.
Just to give you the extent of the issue, in India, we have in my own hospital at this point of time, about 20 patients having mucormycosis involving the orbit, involving the cavernous sinus, involving the paranasal sinuses. And as you mentioned, many of these patients have arterial blocks and infarcts. More than the main presenting symptoms, apart from visual problem, are the major vessel infarcts. That is the issue.
Yeah, they lose their
nothing much can be done about this actually.
The only thing you can do.
Comments. I'm sorry, who's saying that? Keki, yes.
No, they call it the black fungus, and that is because they cause arterial obstruction, narrowing, and the rest of the tissue becomes black because it dies. And in fact, today itself, I operated on one patient, endonasal, and going into the orbit and took out a lot of pus. And that patient also had a huge brain abscess. So it had gone through the orbit into the brain. And unfortunately, the orbit which was involved was the only eye which was seeing. The other eye was blind from childhood due to injury. So we have a real big problem because the treatment of choice is exenteration of the eyeball along with the orbital contents. You cannot be lenient with mucormycosis. Otherwise, it's going to simply keep on spreading.
Yeah, it's a deadly disease.
That's a very good point, Keki. And actually, we've had a few cases in Oxford, and we've used the approach Bill described, where you go through the orbit when you excentrate, and you get a very good control into the cavernous sinus, and you can use microsurgical technique nicely on the carotid if needed. But thank you very much for an excellent talk, Professor Caldwell. I think I'll hand back now to Professor Kannan for his closing remarks. Thank you.
I'm sure I'd like to thank all the speakers and the faculty. Bill, thank you very much for this expedited review of the orbital surgery for these indications. Luciano, it's always a pleasure to see you, and it was fantastic. Olga, it's great to have you back, and we are going to invite you on a future webinar. Don't hide from us. We were searching for your email, and it tends to be the same one. I'd like to thank the penalties members, Goel, that you joined us today, and Keki as well, and gave some flavor for the discussion. I think our Japanese colleague, they went into sleep now. I don't see any of them on the webinar. I'd like to thank the attendees, and on behalf of the members of the committee, I'd like to expedite our appreciation to your continuous contribution. I'm seeing Ramesh here now. Okay, hi Ramesh.
Hi, sorry, I was...
You catch up with the, okay. Well, have a good night, or a good day, and thank you very much again. Take care.
Thank you.
Thank you. Bye-bye. Thanks.
And bye Takashi, Japanese and still
Oh,
away.
here, Takashi Kong is here. Yeah.
Bye.
See you tomorrow.
Good to see you, Atul. Keki.
Yeah.
Before you leave, guys, let's have a group pictures with.
Can I make a snap?
Stuff. But Luciano is a picture dark. Can you make light for your in your room or?
Yeah, I can.
Yeah, you are better. Okay.
So can I ask for a big smile?
Thanks, everybody.
Thank you.
Thank you.
Bye.
Bye-bye.